Nah, I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave. The night is electrical. I've been told y'all this is cinema. I am on my Cooper car like a Spielberg, close to kind of fall. Feeling awesome to be back. Then I'm making all competition, making what I want, that's a flex. Get me what you want, I ain't got a bench. Slow up when no one is your gun. Magic, I'm feeling my palms, make them go down with them arms. Nah, I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave. The industry's so full of shit. Welcome y'all to the enema. Nah, man, no subliminal. Cause the insecure, they know who they are. Feeling awesome to be back. In the American all competition. Everything that I do is a flex. If you don't give me, not make you bitch. Slow up and no one is so good. Got the magic in my palms. Make them go down with them arms. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. I ain't riding no waves. See, making my own waves, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave.
Your plans to make me with some other guy Good afternoon, everyone. How are we feeling? Oh, 3 people are feeling okay. That's good. Hopefully we're all pumped. We've had a good day exploring Seminyak. We've been out and about because that is what this conference is all about. It really is about getting out there and enjoying the amazing location that we're in. If anyone is unsure of things to do, whether that's further afield day trips, places to eat, beach clubs to go hit up, please don't hesitate to go speak to Delphine, Max or Choc, which are outside set up at our registration desk. They're able to give you all sorts of advice as well as book any tours that you guys might like to get onto. As I said last night, we're really stoked to have you guys all here. These conferences wouldn't be possible without you all. So let's give yourselves and our presenters that we're going to have this week a big round of applause to get us started. So for those who didn't hear last night, I'm Quentin. We've got Dylan there in the corner working the streaming. And with our EMS conferences, we try not to talk too much. So that's the good news for you guys. We leave it to the experts, the people who know what they're doing. What we do try and do, though, is give away prizes. So we've got prizes from Emergency Fit, which are Rebel Sports vouchers. We've also got prizes from Everest Wealth, which are Dan Murphy vouchers. The way that you can win these vouchers during the week is submitting your photos. So in our info guidebooks that you might have found a little QR code in the bags, there's a bit more information on it, but pretty much all you have to do is tag us on your socials. And each day we'll be picking the top sort of 5 to 8 photos. We'll throw them up, loudest cheer gets the prizes. As a hot tip, get in early during the week because as the week progresses, more photos come in. So hopefully we'll see some of those photos coming through and we're going to start that one off tomorrow morning. Today we've got a few presentations to get through. I'll be back sort of between the two, but please feel free at any stage if you guys need to grab any food, any drink. The bathrooms are out the door to the left and sort of on this level here. Please do so. And if you do need any assistance, please just shout out to Dylan and I and we can help you out. So it's always a hard task presenting to a group, and it's even harder doing it on day one. So I think it deserves an extra loud cheer for our first presenter coming up. Matt, let's hear it for Matt.
Good afternoon, everyone. Good afternoon. Sorry, guys. I'm Matt McKnoulty. I'm a obstetrician and gynecologist based in Brisbane. Oh, that's better. Sorry. I'm Matt McKnoulty. I'm an obstetrician and gynecologist based in Brisbane. Caitlin, Fiegert and I are going to present the first approximately hour and a half with you this afternoon, looking at problems in pregnancy. So Caitlin's going to start with you and do a little presentation specifically looking at early pregnancy. She's currently a PHO working in Toowoomba, who has just finished one of her important diploma exams, which is great, and is very keen on working in a rural and remote setting. She's going to start today by presenting on bleeding in early pregnancy, following which we're going to do a quick Q&A and try to get some questions from the floor and have a bit of an open discussion. And then I'll present on some common complaints in late pregnancy before finalising with a Q&A as well. So the Q&A is going to be very much dependent on your guys' involvement. And we'd love to hear some questions that maybe you've seen in your practice, you know, that a weird random friend or aunt or sister has asked you over the time. As you know, anyone who works in healthcare knows, you get questions about anything related to any part of the body at any time, no matter whether you have any idea about it at all. So if you could please put your hands together for Caitlin, she'll start us off.
Thank you. Hi everyone, so I'm Caitlin and I'm going to present on bleeding in early pregnancy. Just a few things I hope you can take away from today. So what some differential diagnosis might be for bleeding in early pregnancy, the management and pathways for things like miscarriage and ectopic pregnancies, speculums. I know everyone's really a bit nervous when the speculums come out, but we can have a talk about a few tips and tricks, and then appropriate escalation to your O&G team. So just a raise of hands, like who feels comfortable with managing bleeding in the ED setting? Amazing. Amazing, amazing. So that's so fabulous. So if you take something away, that's great. If you're like, I'm already just so amazing at this, that's good. For those of you who don't feel comfortable, that's even better, because hopefully you'll learn something from my talk today. So bleeding in early pregnancy, it can be anything. It can be anything from spotting to severe life-threatening bleeding. 25% of pregnant patients who do have bleeding in early pregnancy go on to have a viable pregnancy delivered at term. Miscarriage is unfortunately very common. It affects about 1 in 6 pregnant people, and an ectopic pregnancy is responsible for about 1% of all pregnancies, with a recurrence rate of around 10%. So just keeping in the back of your mind a few of these differential diagnoses. So ones that are specifically pregnancy related are things like miscarriage, ectopic, ectropion, perigestational hematoma, molar pregnancy and implantation bleeding, and things that are not strictly pregnancy related but can still occur in pregnancy is infection like pelvic inflammatory disease, STIs, thrush or bacterial vaginosis, malignancy, polyps, fibroids, trauma or bleeding from other places such as the bladder or the bowel. So this is the first case, so flashes up on your whatever system you use for ED. So triage cat 3, a 26-year-old female with abdominal pain and some small PV spotting. Her obs, she's got a blood pressure of 110 on 70, heart rate of 110, rest rate of 10, normal sats, she's afebrile. So first things first, obviously you're going to take a history from the patient. So any patient that presents to the ED that's of reproductive age with abdominal pain should be investigated for a pregnancy. So doing some bloods during a urine test would be the first thing to take off while you're speaking to them. Taking an appropriate pain history, trying to define the onset of the bleeding, when did it happen, has this happened before? Then the quantity of how much blood they've lost, which can be really tricky, but generally speaking, we talk about 1 pad per hour is potentially too much bleeding and you should come to the hospital with that. If you're having any large clots as well, that would be a reason for patients to present to the ED, or for people bringing them to the ED to say, yes, it's appropriate to come in. Has it happened before? Were there any triggers? So perhaps they've had a transvaginal ultrasound maybe earlier that day, or they've had recent intercourse and that's caused bleeding. Have they had any pain relief? And what are the other associated symptoms? So obviously pain being one of them, but specifically, is there any shoulder tip pain? Taking an O&G history, so that includes seeing how many pregnancies they've had previously. So that's what the G stands for when you see people say G's and P's, and how many pregnancies they've had, so how many births. And then there's the other letters like M for miscarriage, E for ectopic, T for termination. Touching on their period, if there's been any other episodes of bleeding, and checking to see if their cervical screening test is up to date, as well as if they're currently using any forms of contraception. Taking a sexual history as well, and then a normal past medical, surgical and social history. So the first patient, this is Bella. She is a 26-year-old lady who's had a positive home pregnancy test Friday last week. She's not been to see her GP yet. She woke up this morning with sharp right iliac fossa pain, cramping in nature. She's used some simple analgesia, but she's still got 7 out of 10 pain, but you think she's looking pretty stoic in the bed. She's had some light spotting this morning, and she's 2 weeks late for her period. She's not had to change a pad yet in the ED. Last period was 6 weeks ago. Her CST is up to date. She's never had an issue with a speculum before. Previously had chlamydia, treated 4 years ago for this, and not currently taking any contraception. She's waiting to have a Mirena put in. So next, you'd move on to examination. So things that you're looking for on examination is obviously her obs. So we've looked at the ones earlier. Feeling her abdomen, is it distended? Can you feel any mass? Any signs of peritonism? Moving on to a speculum exam. So specs are super important in this setting as well, because she has had some bleeding, so to see if there's any bleeding actively coming from the cervix, and then potentially doing a bimanual examination to see if there's any kind of fullness in the adnexa or any tenderness on exam. Particularly with the obs, keeping in mind that young women will compensate really well, even if they've got, say a litre of blood in their pelvis. So keeping in mind that any sort of derangement in the obs, whether that be hypotension or a tachycardia, is important to let everyone in the team know. So for Bella, she is alert and orientated. She looks a little bit pale and has a normal BMI. Blood pressure is now 90 on 60, so before it was 110 on 70. She's got a heart rate of 115. She's breathing up a little bit, still afebrile. Her abdomen feels distended. She's maximally tender in the riff. You've done a speculum exam. Her cervix looks normal, but it was really uncomfortable for her. And on bimanual exam, you can feel a fullness in the right adnexa. And because you're already so fabulous and put into cannulas and took some bloods, her investigations are back now too. She's got a hemoglobin of 90. She's a negative blood group and a HCG of 2,500. So then thinking about, do you do an ultrasound or a bedside scan? I apologise for the ED people in here who know that it's not a fast scan. That's my fault. So the bedside ultrasound shows that there's lots of free fluid in her pelvis. And then just so happens that the sonographer's walking past as well and can do a really targeted exam, and they can see that there's a small ectopic pregnancy. So the diagnosis for this lady is a ruptured ectopic pregnancy. So what do you do next? So you've found this woman in the ED, her obs are getting worse. Who do you call? You call me if you're in Toowoomba, and you do like a normal ISPA handover, which I'm sure you're all fantastic at doing. So who you are, where you are, what you think the situation is. So this is a ruptured ectopic pregnancy with a woman who's becoming hemodynamically unstable, and you'd like an urgent review from O&G in the ED. So as I'm coming down, things that you could do are making sure she's had a cross match so we can replace any blood, starting some fluids, making sure she's got dual access, so 2 large cannulas, and then we'll hopefully take her to theatre. So this picture is what a ruptured ectopic looks like for us when we do a laparoscopic surgery. So doing this thing. Oh yes, cool. So this is the ruptured ectopic, that's the ovary, and that's the uterus there at the back, and then all of that is obviously blood in her pelvis. And then this is sort of what it looks like when it hasn't ruptured quite as much. So again, where that circle is the ruptured ectopic, but there's some blood you can see down in the pelvis as well, so that would still be a ruptured ectopic. So just briefly, like I said earlier, 1 to 2% of pregnancies are ectopic in nature. About 95% of them occur within the fallopian tube. 18% of ectopic pregnancies will rupture. And ectopic pregnancies are responsible for 80% of first trimester maternal deaths. So we don't have a lot of maternal death in Australia, but in the first trimester, a ruptured ectopic that isn't treated or escalated appropriately, or the bleeding's so severe they can cause maternal deaths. Risk factors include smoking, advanced maternal age, a previous ectopic, previous pelvic infections, known tubal pathology, and if they've had a previous sterilisation procedure like having their tubes tied. This is just something I thought was interesting. We had a lady in Toowoomba earlier this year who had a corneal ectopic. So this photo is obviously presented with consent, and it was reported as a laparoscopic ectopic pregnancy, a tubal ectopic, sorry. But as you can see, it's sort of really close within the uterus. So we ended up managing her with methotrexate, which leads me to my next point. The management. So for our lady, for Bella, she would need surgical management because she had pain and evidence of rupture, but there are sort of 3 streams of pathway you could manage an ectopic pregnancy. So E is expectant, so they need to have a falling HCG, tubal mass of less than 3 centimetres, and be pain-free and live within 24 hours, live in an area with 24-hour emergency access. M is for medical, so that's using a medication known as methotrexate. Obviously, it doesn't come without risk because using methotrexate, some of you might know that from chemotherapy patients or patients with things like rheumatoid arthritis, and that's obviously toxic to a pregnancy, so that there's a delay in returning to trying to conceive. And then finally, S is surgical management. So this is for if it's a patient preference, a patient that has hemodynamic instability, pain, evidence of rupture, or any other indications that contradict medical or surgical, like an allergy or something like that. Amazing. So next, you've packaged Bella up. She's coming to theatre, and you pick up your next patient. So triage Cat 3. 19-year-old female with vaginal bleeding, a blood pressure of 110 on 60, heart rate of 90, rest rate again of 10, normal sats, and again afebrile. So you pick up Kelly and again, you take a history. So Kelly, this is the first time she's had such heavy vaginal bleeding. She's soaked through 3 pads in the last hour. It's cramping in nature and with some relief with a heat pack. She hasn't tried any analgesia. She had a faint at home this morning and that's what prompted her boyfriend to call 000. She had a last period 7 weeks ago and did a home pregnancy test last week, which was positive, and she's seeing her GP tomorrow or in 2 days' time. She's not on contraception currently, no other medical or surgical history, non-smoker. She's never been pregnant before, and so this would be her first pregnancy. So a common question that gets asked to me, do I do a speculum in this scenario? Speculums are a routine part of a gynecological exam. There's very few times that I would say, oh, don't worry about a spec. The reason you're going to do one is because it can help quantify where the bleeding's coming from. So is it coming from the cervical os, so the opening, or is it from, some change on the cervix like an ectropion? It helps to quantify the amount of bleeding. Is it still ongoing? Is there something called retained products of conception in the os? And it also provides an opportunity to do a cervical screening test or an STI screen. Equally, sometimes these patients get something called cervical shock, and the way to treat that is to do a speculum, see what's stuck in the cervix and take it out, which is normally the products. So some tips that I have for speculums, because we often get asked about that. Sorry, I'm just scrolling down on my notes. Can you just help me with the mouse? I'm so sorry. I just can't find the mouse on here. Sorry. Cool. And then I just want to scroll that bit down. Oh, there it goes. Thank you. So tips that I have for a speculum. So always have a chaperone. ED isn't always the most pleasant place to do a speculum exam, but I often, if I do one down there, either spin the bed or spin the patient around on the bed so then their sort of legs are facing the wall rather than the curtain where it opens. And always be prepared. So I make sure I've got my spec. Often in ED they have the ones with the light, which are just fantastic. But if they don't have one, you could use the patient's phone for a torch. I think that's pretty self-explanatory why you'd use the patient's phone rather than your own. I make sure I've got sponge forceps, some gauze and some pads for afterwards. I get a towel and roll it up under the patient's lower back to help tilt the pelvis, which is really helpful to do. And then I just ask them to bring their feet up to their bottom, put the soles of their feet together and relax their legs apart the best they can. And obviously warn them as you're about to start. So the next page is a picture of a few cervixes. So this is what hopefully you'll see if you can position your speculum right. I appreciate that it's difficult sometimes. I also tell people angling more posteriorly and then opening up is more helpful, and then you can rearrange yourself from there. So the first picture, that's a normal cervix with an IUD or a Marina string coming through. That's very normal. The second picture is cervicitis from maybe chlamydia or gonorrhea, something that's causing some pus coming from the cervix. The third picture is what an ectropion looks like. So if you saw that, that's fairly normal, and that can cause bleeding because those brighter red cells are quite friable. And does anyone know what the last picture might be? So that's what retained products in the os looks like. So if you were to see that, remove it, and that's what the sponge forceps will be for, just keeping in mind that you don't want to put the forceps into the cervix. So what I often, if I see this or if I'm helping one of the my ED colleagues do this, I will often get the patient to cough or to bear down slightly to help it bring the products out, and then you can grab onto it and pull them out. Something as simple as removing them, that will be hopefully what stops the bleeding and really settles it down. If you can't do that, or if it's too difficult, ring me and I'll come and help you, or if I can't do it, we'll go to theatre and help her. So investigations, again, you've put in 2 large cannulas because she came in bleeding quite heavily, and the bloods have come back. So she's got a hemoglobin of 112, a HCG of 13,000, and she's a positive blood group. Her urine's negative. We're tossing up whether we're going to do an ultrasound because you were so amazing at getting the retained products out of the os, and her bleeding's completely stopped now, and then swabs for an STI screen or potentially doing a first pass urine as well. Just a little note on the HCG. So whilst it's important for us to know because we can then say, yes, you are pregnant or not pregnant. Doesn't necessarily correlate to how many weeks pregnant. What's important for us to know is whether we'll be able to see an intrauterine pregnancy with that. So both of these cases, it's been over 2,000. So we should be able to see an intrauterine pregnancy if it's there. But keeping in mind, ectopic pregnancies can rupture at a much lower HCG as well. Okay, so just briefly on miscarriage. So some risk factors for miscarriage include, again, advanced maternal age, smoking, a previous miscarriage, a high BMI, any kind of maternal chronic health conditions, fetal abnormalities or lifestyle factors. Miscarriage, as I said earlier, about 1 in 6 women will unfortunately experience a miscarriage. Only 5% go on to have 2 miscarriages in a row and 1% go on to have 3 in a row. Whilst we know that optimising these risk factors can reduce the risk of miscarriage, ultimately, once the process has started, there's not much we can do to prevent it from happening. And only in about 2% of women, unfortunately, experience a miscarriage after seeing a fetal heartbeat. So obviously always treating these situations with being sensitive and being kind, because often it's really devastating for these people who are really wanting to start a family. So types of miscarriage, so there's threatened miscarriage, so that could be from something like the perigestational hematoma that I talked about earlier, when there's a bit of blood that's formed next to where the pregnancy is implanted that comes away, or from an ectropion, that could be threatened but there's still a viable intrauterine pregnancy. Complete is obviously when everything from the uterus has come out and it would be now empty on ultrasound. Incomplete is when some products have passed away but there's still evidence of retained products of conception on the ultrasound. Or there's miscarriage, which is asymptomatic pregnancy loss. So miscarriage, this is the criteria that we see that we know meets for miscarriage, and this criteria is 100% specific with a positive predictive value, and therefore there's absolutely no chance of an ongoing intrauterine pregnancy if these criteria are met. So that's a crown rump length of 7 millimetres or more and no fetal heart rate, a mean sac diameter of 25 millimetres or more with no fetal pole, absence of embryo with a heartbeat after 2 weeks with a gestational sac without a yolk sac, and then absence of embryo with a heartbeat after 11 days on an ultrasound that showed a gestational sac with a yolk sac, or any ultrasound that now demonstrates there's no longer a fetal heartbeat after previously seeing one. So for Kelly, we did arrange an ultrasound for her because we weren't quite sure if we got all of the products, and it just shows that there's some clot there but no retained products. She's bleeding has slowed right down. She's only changed her pad once in the last 4 hours since we did that speculum. She feels well. Her obs are all normal now. She is emotionally feeling a bit unsure and wants to know what follow-up she needs. So management again, so if she was hemodynamically unstable or we didn't have any success with removing the products, you would call the O&G team. But if she was hemodynamically stable and suitable for discharge from the ED, you could follow up with your local early pregnancy service, which most hospitals have, and they're really fabulous at supporting the women, checking in, and also, of course, the medical process that follows this, or we could refer her back to the GP. Management of miscarriage, so there's obviously expectant, so waiting and watching, or there's medical management, which, for example, a miscarriage, we'd give them 200 milligrams of mifepristone and then another 800 micrograms of misoprostol 48 hours later. This has an 80% of success rate, with the mifepristone increasing the success rate. The mifepristone stops the pregnant causes the placenta and the embryo to detach from the lining of the uterus, helps to soften and dilate the cervix, and primes the myometrium for the misoprostol to be more effective. 8% of medically managed miscarriages go on to need a suction DNC. And then there's a surgical management, which is a suction dilatation and cure and charge, or DNC. And that has a 90% success rate, but does require a general anaesthetic. So sometimes people feel a bit apprehensive about having to go to sleep. There's also something called a manual vacuum aspirate that you can do under a paracervical block. I've not had any experience with this, unfortunately, so I can't really speak to it, but some hospitals in Queensland I know do offer that. So again, this is the guideline, sort of the algorithm. If providing she's hemodynamically stable, we don't think it's gestational trophoblastic disease, no, marina in situ or any allergy or any medical problems that increase her risk for hemorrhage, it would be appropriate for her to have medical management or a trial of expectant management, and then any of the other indications, or if it's a patient preference, surgical management would be the option. Just briefly on anti-D. So anti-D is immunisation that we can give for people with a negative blood group to prevent alloisomerization. So we can give this within 72 hours of the miscarriage or the ectopic, whatever it might be. It can also be given up to 10 days post, but the efficacy might be lower for preventing that alloisomerization. If they're 12 weeks or less, it's 250 international units. If it's 12 weeks or more, it's 625. Really important to think about this, especially if we've done the bloods, and remember to prompt the medical team or the O&G's team. Don't forget she's got a negative blood group, because it will be important for her future pregnancies. Safety netting, so really important. I think that in these scenarios, either I'm telling them we need to go to theatre, so they're a bit overwhelmed, or they've just, had their first miscarriage and it was, in the waiting room in ED, which is always not an ideal place for these things to happen. So I think it's really important to give some written information about what's happened and what the follow-up might be like at your local hospital, and telling them when to return. So if the pain's really severe, if they get any shoulder tip pain, if they're soaking through more than a pad an hour, if they're having large clots, fainting, fevers, abnormal discharge, all of those things, come on back to the ED and we can help them there. They might have some other questions about, when they can return to sort of normal life, contraception, future pregnancy planning, all of that kind of thing. It's we can talk about that maybe after if people have questions, but, contraception I think is a great thing to sort of mention even in the ED setting. And we can always print things like TRUE is the Queensland sort of sexual health program, and they've got great advice about contraception. I think it's a really important conversation for all of us to have with these people, especially if they were sort of unplanned pregnancies and things like that. These are what some of the patient handouts look like. So the bluey green ones are from Queensland Health, and then the pink one is from the Women's in Melbourne. So they're really great, really straightforward, and just gives that bit of support to them to be like, oh, where else can I find reliable information from? And this is essentially the flow chart that we've just kind of gone through, and just briefly on pregnancy of unknown location. So they might have a positive HCG, but it's below that 2000, which means we can't always see it on ultrasound, or maybe it was some of the other criteria from miscarriage that says, oh, we're not quite sure, you'll need an ultrasound in another 10 to 14 days to see if there's a viable pregnancy. And generally in early pregnancy clinic, we sort of follow this guideline. So if there's someone with a pregnancy of unknown location, what we'd get you to do is refer them to early pregnancy clinic and give them a slip for another HCG in 48 hours time, and then an additional 48 hours, so we can track either the rise or the fall of their HCG. So some things I hope that you've taken away from me being up here chatting to you is young women will compensate really well. So any kind of derangement in their OBS, escalate that and let your team know. So, hey, her heart rate was 110, now it's 115, the blood pressure's a bit softer. I think there's some bleeding happening here. Great to do. Soaking through more than one pad an hour or having any large clots, that's really heavy bleeding, and we should get them to come to the hospital and see them. A speculum is a part of a general exam, so don't be afraid to do it. I think you're only going to get better by practicing and, asking one of the registrars or one of the consultants to come and help you, or if I'm not too busy, I'm always happy to come down and help and teach people as well. So hopefully most of your O&G regis at your hospital are feeling that way inclined too. Escalation of abnormal vital signs, IV access. So when you're bringing them into the hospital, if you can get a cannula in, get some fluids going for that sort of pre-hospital arrival resuscitation, I think that would be fabulous to be considering. And we want those really big cannulas, so a green or a grey. Pink and blue are pretty, but not in this situation. Checking their rhesus status, thinking about follow-up. So can we see them in the early pregnancy clinic, or do they have a good GP? And then finally, just remembering to be kind and really being mindful of the words you're using talking to these patients, because obviously it's a sensitive time. October is actually Pregnancy Loss and Miscarriage Awareness Month. So whatever's happening for these people, again, really important to be kind, and, it's a hard time. Anyway. Any questions? Amazing. Hopefully I didn't speak too quickly and you can understand most of what I was saying. These are my resources. I finished uni a while ago, so I've forgotten how to format them correctly. But anyway, that's the main point. Cool.
We might use that one. Yeah, okay. Too easy.
Yeah, that's great. Yeah. Yes.
That's the other one. That's what I said to you.
Yep. So, thank you, Caitlin. So, that excellent talk to make sure everyone's got a good understanding of what happens in early pregnancy. Just while Quinton gets my talk up, so what we'll do is we'll go through my talk, which is definitely not as detailed as Caitlin's was, and then at the end we will have kind of an open discussion with everyone. So if you guys can think of any conditions that you've seen in pregnancy, any weird and wonderful things, even if it's just a comment, even if it's say, look, I've seen this really interesting thing to let everyone else know about it, that'd be great. Thanks, mate. That'd be great. We'll hold that off towards the end. So look, as I said, my name's Matt McKnoulty. I'm a obstetrician and gynecologist who works at Redcliffe in Queensland. In order to work out what to talk to a very broad group of people about who all understand healthcare but maybe not a huge amount of obstetrics, I did the right thing at the moment, and that's get some consumer information and consumer advice. So I spoke to my gynecology clinic nurse, the lovely Mary, and asked her, what would you want to hear about in this situation? And her response was something very simple, and she's like, she's got young daughters, all of whom are now having kids, and they always come to her with bucket loads of questions, particularly at different parts of their pregnancy, about is this right or is this wrong? And she has absolutely not the foggiest idea of what they should be feeling, what they shouldn't be feeling. So the aim of the talk today is going to be really just looking at what are the common issues that our mums will face, particularly in the third trimester, so kind of 30 weeks onwards. And what should those people who aren't obstetrician and gynecologists or GPs or midwives who manage these people on a day-to-day basis, what should you guys know so that you can provide them with some advice and not accidentally say something that might not be terribly helpful? We're going to talk about a couple of things, and when I say brief, I mean it's really brief. I don't want to give you a huge amount of information and for it to all go over your head. Really, we're going to focus on a couple of key things for each of these presentations so that when this pops up in 4 years' time, you'll remember that weird afternoon in Bali that was one of those 4 things written up on a slide, and I can remember those things. So if it's too brief, feel free to yell at me or throw something and we can go in a bit more detail, but we can also go through them in more detail after the fact as well. So abdominal pain, this is probably the most common complaint that we have, and it's really common. I can't imagine I've met too many mums who haven't complained of abdominal pain at some stage, and the reality is there's lots of different causes and reasons why you get pain in pregnancy. And I think part of it is really to do with the fact that everything's really relaxed. So some of the hormones that are released in pregnancy relax the pelvis to make it easier for baby to come out, but at the same time they relax all other ligaments within the pelvis as well as the attachments from the muscles onto the back. The abdominal wall gets relaxed. So everything just gets relaxed and sore. And as you start to get bigger and heavier, things start to stretch and get worse. Pain, though, comes and goes, we call Braxton Hicks. So Braxton Hicks think of the way as the uterus working out how to have a baby. They are irregular, a bit like AF is. They are not... we'll talk about how they're different to labour pains shortly, but they are basically just random pains. They last for anything from 10 seconds up to 2 minutes, and they're a bit all over the place. And generally they start to happen in the third trimester, but they can happen earlier than that. Importantly, there's lots of time in between, there's pain-free, and they're often really variable. So some people will just say, oh, look, I feel a little tightening and a contraction, but some people have to stop what they're doing when they get that pain. The second pain is ligament pain, and this is, again, really common, and it gets worse as people get more pregnant. It tends to be more constant, though. It's worse with movement. It's usually worse in the mornings when they wake up. Rather than being through the whole abdomen, it tends to be more pelvic, so really around the pelvic girdle. And it does, again, as I said, it does tend to not necessarily self-resolve like Braxton Hicks. Braxton Hicks will just go away. Ligament pain kind of tends to be there constantly. Constipation's really, really common. We're very good at throwing lots of iron into pregnant women at the moment, and one of the big side effects of that is constipation. So, a very quick question of, have you opened your bowels recently is a really handy question, because, mums are often second and third time mums, and they're looking after little kids, and they've got way more important things to worry about when the last time they went to the toilet, especially if they haven't gone to the toilet by themselves for a couple of years. So, these are really simple things, that we can try to remember to talk to them about. But there's a couple of things we really don't want to miss, right? And don't worry, that pain's nothing to worry about, and 2 hours later they have a baby is a really embarrassing thing for you to be as a friend who've just been asked for some opinion. So you have to consider labour. Now, the difference between labour and Braxton Hicks is the regularity. So labour pains, you can set your watch to them. So you'll have a pain, and 15 minutes later you'll have a pain, and 15 minutes later you'll have a pain, and then 14 minutes later you'll have a pain. And those pains will start to become quite regular and get closer together, and they get longer and they get more painful. Braxton Hicks, which feel like labour pains, don't do that. So they're a bit all over the place. So you'll have a pain and it'll last for 60 seconds, and then 4 minutes later you'll have a pain and it'll last for 12 seconds, and then 15 minutes later you'll have a pain and it'll last for 14 seconds. And then 25 minutes later you'll have another pain, and that will be the end of it. Right, and so that's a really important key, is if you're getting regular pains and you can literally get them to put a timer on their phone and use a stopwatch to have a look at it. And if they're regular, you'd be a bit worried that they're in labour. Now, obviously, if you're 39 weeks, that's wonderful. If you're 31 weeks, that's less wonderful. So it's also a bit dependent on the context of who you're talking to. Urinary tract infections, obviously really common as well. Again, tend to be more of a common pain, but with the bladder, if it's irritating, it sits on the uterus, it is a known cause of preterm labour. And I guess, true term labour as well. And so sometimes they can have that kind of colicky, irritable uterus pain similar to a Braxton Hicks, but sometimes can look a bit like labour as well. So the other common thing with UTIs, obviously, is they're not usually feeling terribly well. Dysuria is reasonably common. Polyuria, so weeing all the time, is normal regardless, so that's not usually a terribly helpful thing to ask them for. One of the really important things to miss out on is called a placental abruption. Now, it's basically when part of the placenta starts coming away from the uterine wall early. This tends to be a pain that starts like labour and becomes much more constant. So you're not going to have the break in between, and the pain gets worse and worse and worse. One of the really cardinal signs of this as well is vaginal bleeding, but that doesn't happen in all cases. That probably only happens in about 80% of cases, okay? That is an emergency, and that does need assessment straight away. So if you have anyone with pain and vaginal bleeding, they need to come up to the hospital as quickly as possible via an ambulance. And then there are lots of reasons why people have tummy pains many of the time. So if you come to the emergency department, there's about a 50% chance that someone gets the diagnosis of why they got abdominal pain, and probably half of those are made up in the first place, that we just say that that's what the cause of their pain is. But we just need to make sure that they haven't got something like appendicitis as well. So that's abdominal pains. Now, what do you want to ask? Well, look, as I said, the gestation's really important. If someone's having regular abdominal pains in the 39 weeks, and they're probably in labour, and it's a good time to, at least get them to speak to their hospital or whoever's planning to delivering them. We've spoken about the regularity and severity as well, and the vaginal bleeding as well. And infective symptoms are important for all the other non-pregnancy related causes of the abdominal pain. The next one, really common, is headache. Now, most people probably come in with a headache because of everything else happening at home. So again, when you're having a baby, you've often had another baby before, and so there are usually a lot of other things happening in life that makes it quite challenging and difficult, and good reason to have a headache. People who are pregnant do get headaches just from pregnancy. So it's a very common complaint. We haven't got a great reason why. It's probably to do with vasodilation secondary to their estrogen through their brain. There is not a great way around it, but usually they do self-resolve, and they usually get better with time, but it is not uncommon. The really important thing not to miss is something called preeclampsia. I assume most people who have worked in healthcare have heard of preeclampsia, and it's basically a condition that, again, we don't really know what causes preeclampsia. The easiest way to think about it is probably almost an autoimmune condition against the placenta of the baby. And so what they get is their cardinal symptoms are kind of a headache, spotty vision, and then if they check their blood pressure, it's usually elevated above 140 on 90. It's common. It occurs in 9% of all pregnancies, much more likely in people who have had pregnancies in the preeclampsia in previous pregnancies, or first-time mums who haven't been there yet. The most important thing with these headaches is a blood pressure, and it can be any blood pressure. So, mums who have had the history before who don't have their own blood pressure cuff often will jump down to the pharmacy and get one there. there. If you're picking them up in an ambulance, then obviously you're going to have an automatic cuff as well. The problem is automatic cuffs are really not very good for young women. They're really made for 50-year-old men who smoke and drink, and not really dialed in for young, skinny, healthy women. And so often they overcall it. So you might have a blood pressure of 190 on 90 in an ambulance, but when you actually put an automatic cuff on, a manual cuff on, it's actually quite normal. The last thing to miss is something called a venous sinus thrombus. Basically, this is a really rare condition where there's thrombosis within some of the sinuses of the brain. These are really pretty severe headaches. They're the thunderclap headache kind of patients that you've probably seen in ED, or really severe migraines. This is not just a normal headache. They're really unwell and really unhappy. The way that we find this usually is a CT venogram, or they can have an MRI head depending on where you are. But again, if you've got a really severe headache in pregnancy, you really need to be coming up to the hospital. The things we ask about, so vision changes, as I said, preeclampsia, 9% of patients, when you've got a bad headache, you tend to have vision changes as well. And people will always have vision changes, but what we're really looking for is spotty vision. So it's kind of like starry vision if you've ever stood, when you stand up too quickly. And it's really persistent, and it can be really severe to the extent that where they can't see. Edema is normal in pregnancy. Edema is worse in preeclampsia as they get that kind of autoimmune condition. They get a SIRS-like response, so they do get worsening edema. But facial edema is really specific. And so it's really good to ask, family and friends who maybe don't see them all the time about whether they do have any, significant facial edema. And then focal neurology is really just looking for the venous sinus thrombosis in these patients. As I said, the best thing really is a blood pressure if you can do it. If you can't get a blood pressure, there's two other really good ways to work out whether it could be preeclampsia related, and that's kind of neuronal excitability. So we do it with reflexes. Now, has anyone done many reflexes on pregnant women before? I'll kick you in the face really quickly. So everyone's kind of hyper-reflexive. It's really normal. So you can literally use your fingers on their patellar tendon and their leg will kick off, and that's actually quite normal. So if you can use your pinky and do it, and that's probably a little bit hyperreflexic. The other thing we can look at is clonus. Now this is a video that may or may not work. Let's see if we're going to have any luck today. No, I don't think it's going to work. Anyway, very, very simply. So what this nurse is going to do is she's going to pull and dorsiflex the foot, basically put the toes towards the head very quickly, and then the foot is going to bounce many times, okay? Now, that you can do that to, a friend if you want to, and you'll see the same thing. It's normal to have 1 or 2 beats of clonus in just a normal person. This is a really exaggerated response in someone who's got an upper neuron condition that makes it really excessive. In a pregnant patient with preeclampsia, if they're kind of doing it more than 2, 3, 4 times, then you'd say that's a pretty significant level of neural excitability, so you'd be really worried in preeclampsia, right? So if you don't have access to a blood pressure cuff, but you think they're no good, then checking their reflexes and their clonus is not a bad way just to see whether this could be preeclampsia related. Okay, next complication is fluid loss. So with pregnancy, baby is obviously covered in a big pool of amniotic fluid. There's heaps of it. So it's often seen you there. Look, it's a common condition that we see quite regularly. Probably the most common reason we see it, though, is not because patients have broken their waters. So patients who are pregnant have lots and lots of vaginal discharge, to the extent where it's not uncommon to have to wear a pad every day, even if it's just a mild liner, because of that. I guess if you're having to change a liner more than once a day, or if you're actually filling up a liner, you probably do need to be assessed to make sure it's not any more fluid coming out. There's not a really good way to work out what the cause of the fluid is based on smell or look or anything like that. Leukorrhea is a clear discharge, pretty similar to water. It might have a little bit of white discoloration, creamy discoloration to it, but usually not. There's no really good end of the bed way just to see what it is. Urine is not an uncommon thing, so incontinence is really common. The pelvic floor is not very happy with pregnancy. Pelvic floor is not very happy with multiple pregnancies, being it twins or the 4th or 5th or 6th baby. So having a little bit of urine leakage is really, really common as well. Patients do not like being told that that's why they're having all that vaginal loss. But usually it's a better option than some of the other things that could have been happening at the same time. But the thing we really want to make sure of is, have they ruptured their membranes or not, right? And people tend to, when they come in with ruptured membranes, come in with a towel between their legs. The partners or parent is very worried about what the car seat's going to look like because the amount of fluid coming out. It's not generally a small amount, but the thing is, it can be. And so that trick of if it's just a liner or two or a pad or two, but they're kind of filling up, then they really need to have a look. And the way we do that is with a speculum examination. Same thing with, I guess, urine is the other thing we need to make sure is they don't have a urinary tract infection as well. So again, just looking for the symptoms of dysuria and systemic feeling unwell. So eating and drinking normally, whether they're nauseous at all, and that's usually a pretty easy thing to do, is to get a dipstick. What do you need to know? Well, again, if they're 39 weeks and they come with a big gush of fluid, then they've probably broken their waters and they're probably going to have a baby soon. If they have that big fluid loss and they're having pain again, we'd be worried about them going into labour, and that's fine if they're allowed to, but if they're really early, we'd prefer not to. Colour and amount are helpful because, as I said, if it's really small amounts and it's not really bothering them, it's often not a thing we have to worry about. Almost everyone in Australia will have reasonably rapid and quick access to a midwife or an obstetrician via the phone 24 hours a day, to ask these questions. So if you're ever faced with a family member or a friend or something asking you these questions, then almost universally they will be able to call the hospital they're delivering at and speak to a midwife and speak to them about the same question as well. All right, so it's not something you always have to take it on board that you're going to take all responsibility for the outcomes of this patient and their pregnancy. You can usually get them to call for help. Funnily enough, we're not very good at actually reminding our patients that they do have that option available. And that's that one. Reduced fetal movement. So this is a really common condition. This is something that's probably going to become more and more of an issue with everybody, and that's simply because we're getting much better at talking to our patients about it. So there's a couple of really good resources running at the moment. So the Centre for Stillbirth Alliance runs a nationwide push in all maternity hospitals about the importance of informing mums about the importance of fetal movements. Queensland recently has put out, when I say recently, it was about 6 years ago now, but was reasonably recently when I started my work on this. They talked about finally had a guideline about what to do with these patients, because 50% of all our mums will present at some stage to the hospital, which is an awful lot, with patients with baby not moving well enough. Now, they can happen at any stage of the gestation. Up until 28 weeks, there isn't really such a thing as normal fetal movements because the brain's just not developed enough to make normal movements for baby. So we don't stress too much in that kind of up to 28 weeks. 24 to 28 is a little bit of a grey area, but certainly up to 28 weeks, we don't think there's too much happening after that. But the reality is what's normal? Does anyone... I'd love just one person to respond, that'd be great. Does anyone have any idea of what normal movements are? What they would consider normal? Oh, very good. That is 100% the right answer. Cool. So that is the best answer, which is everyone is dependent. So it's really when mums are worried, we are worried, okay? There is heaps of research out there on what a baby movements should be, but basically each pregnancy is different, and so when the pattern changes, that's when it is deemed abnormal, okay? Some babies will move, hundreds and hundreds and hundreds of times in a day, and some babies will move 5. But if those things change, then that's the concern that we worry about. Now, I guess the question is, does anyone know why reduced fetal movements matters? So, a baby doesn't move. That's okay. Sometimes we just sit on the couch and don't do very much for the day as well. But does anyone know why we worry about it? Yeah, very good, yeah. So it's kind of the only really good way the baby can tell us whether there's something might be happening, right? And the problem is the babies, they overcall all the time. So 50% of the time they're not, moving for whatever reason, but often there's nothing wrong with them. The reason is that 75% of all patients who have a stillbirth complain of reduced fetal movements before it happens, okay? So we're trying to capture these individuals at the time of baby not moving to try to prevent stillbirth. Now, are we very good at it? Absolutely not. We're not very good at it at all. But what we try to be able to do is identify these babies that might have something wrong with them that we could potentially identify before something catastrophic like a stillbirth happens. So what do they need? They need to come and see their midwife or their obstetrician for assessment. And what do we do for them? We'll do what's called a CTG, so it's basically a long-running heartbeat where we use pattern recognition to determine how well baby's oxygenated, which is very good at assessing how that baby is right there, but not terribly useful in 10 minutes' time. And then we'll usually do an ultrasound scan for them, because with these babies, what we're trying to identify is those babies who aren't growing very well. So an ultrasound scan will be looking for babies who are growth restricted and aren't getting there. Okay, so if you've got a friend or a family member who says to you, my baby's not moving terribly well, then they need to get in contact with whoever's planning to deliver them to come in for assessment every single time, even if they were seen yesterday. Okay, so if a patient comes in to speak to us and say the baby's not moving, great. If they're not moving well tomorrow, you come straight back. All right. The best possible outcome when they come and see us is that they get to go home and there's no problems at all. Okay, so when people come in and they think a waste of time is the best possible outcome, when it wasn't a waste of time, it's not usually a good sign that something's going well. Vaginal bleeding. So we call this an antepartum hemorrhage for really fancy words, not really important. It can be anything from a couple of little spots on the toilet paper, and that is as significant as a big bleed, okay? Most commonly, it's nothing much to worry about. Most commonly, it's just a little bit of the edge of the placenta that starts to bleed a little bit, or it happens post-coitally. So again, either way, if someone ever speaks to you, should we be coming in to see someone, should we have a bleed? The answer is always yes, absolutely. When patients get closer towards having a baby, they usually lose what's called their mucus plug. It means nothing. It can happen at any stage. There's often blood mixed in with it though. And so often if there's blood with heaps of mucus, we don't worry about it too much. Again, we still always want to assess them and just make sure that's the case. But sometimes we just don't find any reason. So they just come in, they have some bleeding. We make sure that it's not coming from their urine, so we do a urine stip. Most people know if it's coming from their backside. But hemorrhoids is not an uncommon problem of pregnancy as well. But most of the time we don't find a reason, and that's okay. No reason's fine. But what we want to not miss is a placental abruption, which we've kind of talked about briefly in terms of that pain associated with it. And the placenta previa is basically just when the placenta is low and overlying the cervix, okay? Most 15 years ago, scans weren't as common. Patients would have one scan in their pregnancy, and that's mainly to find out where the placenta was, and to make sure kind of baby had all the right number of fingers and toes and things. These days, patients have 15 or 16 million different ultrasound scans, and so we look where the placenta is a million different times, and patients very rarely don't know, whether they've got a placenta previa. So usually if that's the case, you see someone, they'll know that they've got a low placenta, and someone should have already spoken to them about what happens when they are bleeding. Now, what do we all know? So pain is very important. The reason I'm looking at it this way is, by the way, I just can't see it properly on this screen, so I do apologise, I'm not looking at you at all times. The pain's really important, so we worry about that placental abruption always. That's kind of the thing that's in the back of our head whenever someone comes in with bleeding, and so pain's the key. People don't have a placental abruption without pain, or if they do, it's probably not terribly clinically important, and if it is there, it will get worse. We want to know where the placenta is because of placenta previa, and then we also want to know is there anything that's kind of aggravated and causes bleeding in the first place. So trauma is often a precursor to the abruption just spontaneously happening, and intercourse often happens with postcoital bleeding, and that's usually from the cervix. But as I said, patients always need review. Now, these are kind of getting into more what happens after somebody's had a baby. So PPH, postpartum hemorrhage, occurs in about 10% of all patients who have a pregnancy and deliver a baby. We classify anyone with a PPH over 500 mils, and that will be the vast majority of people will have somewhere between 500 mils and a litre, but patients can have litres and litres and litres loss. It's pretty significant. 70% of cases are just caused by the uterus not contracting down properly. The uterus is very clever. Once it expels baby in a placenta, it contracts down on itself, and it basically stops the blood flow to it. So the uterine arteries themselves have about 700 mils a minute into the uterus itself, and then that goes in through this kind of plexus of vessels that run through the myometrium, which is the muscle of the uterus. And the way that they stop is by contracting down on itself. Now, times where we usually see patients have these big bleeds, have really, really quick births. Okay, so that's often where a lot of people in this room will be here if they turn up to the emergency department or the ambulance because they've had a baby very, very quickly. In which case, often the uterus just doesn't contract down terribly well, or if they've had a very, very prolonged and extended birth. So if they've planned for a home birth or something like that, and it hasn't gone terribly well, and or they've been in labour for a very long period of time, the uterus is just tired and it can't relax down properly. Sometimes, though, the placenta doesn't come out, or it doesn't come out completely, and so retained tissue or placenta itself accounts for about 20% of cases. The other thing is babies come out and they cause trauma down on the way. So most commonly it's this lower tract. So think lower part of the vagina or at the perineum is the most common, but it can be anywhere up the vagina, up including to the cervix. There's a fourth one, which I'm not talking about today, which is basically coagulopathy, which is incredibly rare and not something that we need to just go into great detail. So what can you do? So the first thing is, if you're seeing this patient, if you pull over on the side of the road and somebody's had a baby and they're deciding to bleed quite extensively, the first thing we need to do is get the placenta out. So that's often the first case, and all we need to do with that is just cause some gentle traction and pull it out gently, okay? Potentially, if it's delayed, it can take up to 30 minutes, even up to an hour in some cases. If someone's bleeding really heavily, though, you can basically guard the uterus, which I'll show a picture of in a second, with that patient, with the staff members there, their left hand, they're guarding the uterus, and then on the other hand, in that situation, you would grab the cord and pull gently down. You're kind of between the buttocks is the best way to do it. The other thing we can do is placental massage. So this is basically rubbing the placenta as hard as you possibly can, and it basically responds to the massage by contracting down. In the 1800s, they used to talk about having somebody sit on the patient who weighs no more than 8 stone with a large textbook, and so that was the way they'd manage people who had PPHs. And so when you're doing this, you can't be gentle. If you're being gentle and the patient doesn't care, then you're not doing a very good job and you're not really helping them in the situation. So as we all know, in an emergency situation, there's the right way to do things and there's the nice way to do things, and not always those two things marrying up. So you really have to really use quite a lot of force when doing this. And again, you're doing this in a situation that is life-threatening, and you're not doing it to be mean or rude or cruel. You're doing it because you're in a situation where the patient's bleeding quite heavily, and this is a really good and effective way of stopping them, okay? Bimanual compression is basically that same thing, but in a much more extreme example. So that is when you have a fist inside the vagina, and you can fit a fist inside the vagina after a baby's come out because it's usually much smaller than the baby, and then basically you're putting really strong pressure and massage on the uterus on either side, okay? This is obviously, again, not something that's really well tolerated by a patient. So, having a conversation with them and speaking to them is really important in this situation. And, in my experience, to be honest, patients are actually really receptive to this, right? They usually understand by the look in your eyes that there's something quite significant happening. And so they understand that there's, discomfort that they might be going through in these situations. Fortunately, in hospital, we don't tend to have to worry about doing that kind of thing too much because we do have access to an operating theatre, but no, we're in a very lucky situation where we have those things available where that's not always the case. If it's just something as simple as the perineum that's bleeding, pressure is just as good. So just getting a sponge or anything you've got just to put pressure on there is usually a very effective way to stop it, and often it will really significantly reduce just with pressure on the area. Cord prolapse, something else commonly that can happen. So again, in an emergency situation. So this is when the baby's cord comes down past the presenting part of the head through the cervix. Now, this is a emergency, and that is because the cord is basically the baby's snorkel. It's the only way they get any oxygen, and if it is blocked off, they do not breathe. Now, they are much more clever than we are. They can withstand no oxygen for about 10 minutes because of their fetal hemoglobin. And after 10 minutes, they start to become hypoxic and acidic enough where they start to get brain injuries and things. So, it's really important. And the trick is just to get some level of blood flow through them. And in the most simplistic way, that is to try to remove the thing that's squashing the cord. So these are a couple of different ways we can do it. So one is in the top right there. Ooh. There it is. So that's basically using your fingers to lift the presenting part. In this case, it's a head. Often it's not. Often it's a shoulder or a bum, and that's why, unfortunately, the cords come out. But it's basically lifting the head off the cervix and so that it's not squishing it down. So the easiest way to think about it is it's like a baby's head sitting in a bowl. Okay, now when you rupture your membranes, there's not a huge amount of space for that fluid to rush out around baby's head, but often these situations is because there's not a head down there, there's something else. But if that head or something, that presenting part pushes down into that bowl, it'll fit really nicely and squish whatever's in there. So the aim is to kind of push it up off that to try to keep pressure off that cord until we can get baby out a different way. We can use other things. We can use gravity. So one of the ways we can do it is if you're in a situation where you don't have much help, you haven't got an ambulance bed or a hospital bed that can kind of put mum in a Trendelenburg position with their head down, is you can get them on all fours and put their bum up in the air. You can also try to get a wedge or something under their knees to even help more than that. So, and you can do this and that at the same time, and ideally that's a great way to do it. This is another way. When these things happen, often patients are in labour, so holding this position for a long period of time is not always easier. Sometimes you need to get them in a position which is easier, so you can actually lift them up on pillows under their abdomen as well, rather than them having their pressure on their knees. Again, same thing. You can you use the pressure, and usually this person has to stay like that until baby comes out. So if they're in hospital, that's not too long. If they're at home, that's obviously a long period of time. Other things you can do in a simple situation is if you've got access to a catheter and some water, you can actually blow their bladder up as well. So the bladder is really handy. Again, it just sits at the front there. And so if you can fill that space up, it will actually lift baby's head up as well. And you can do it that way. But the trick with these ones really is they need delivery. If you're lucky enough to have, again, if you're in an ambulance, you might have some salbutamol. Salbutamol is not a bad option. We don't really use it regularly, but salbutamol is uterine relaxant, so you can give them some of that. GTN also works pretty well. Okay. The problem is that these patients tend to have pretty low blood pressures, so they may have some hypotension from that as well. We use terbutaline. No one's going to have terbutaline unless you're in the hospital, so not terribly useful. And what I said, they need delivery. And in the vast majority of cases, that's going to be a cesarean section. Now, I guess one of the other really important things is, if you have to deliver a baby. Now, the good thing is babies used to come out well before obstetricians and midwives were around, and they used to do a pretty good job of it by themselves. And so most of the time, you don't really have to do very much. It's just, probably the most important thing is they're really slippery, so try not to drop them. And that's, so you just make sure you grab them in nice, good ways. So, grabbing them around the neck before their shoulders are out, or holding them around the shoulders and underneath their arms are really important. But the first thing is just, don't stress. These things are natural. Yes, it's a weird, wonderful position to get yourself into, but no one is expecting you to be an expert at the time. So you're just kind of there to, be supportive and help as best as you can. Nature's pretty good at sorting itself out. So as I said, baby will tend to come, and mums kind of have this inbuilt innate ability to be able to deliver a baby without anyone there being very helpful. So don't worry too much. Things take lots of time. So that's the most important thing. If you have a baby, oh my God, the baby's coming, it still might be 30 minutes before it comes, okay? So when you think, things aren't happening very quickly, that's pretty normal. You might see a baby, you might see a really little bit of their head coming out here. But in a first-time mum, going from A to B to C might take 30 or 40 minutes, okay? And that's not, there's nothing you can really do about that if you're not in a hospital setting, and there's not necessarily anything you need to do about that. That can be perfectly normal. Really what they're doing here is they're just having their hands there ready to kind of catch baby and to make sure it doesn't shoot out really quickly. Because again, from kind of A, B, and C, baby with one push can be out on the bed right in front of them with a really big push, especially if mum's had some babies before. So just having your hands there ready to go, a bit like if you're in the slips, is really handy to make sure that you don't miss catching the baby at all. If you are getting, if mum is in a position where there's kind of baby's not coming out and they're lying on their back like this in lithotomy, getting them to change positions is really good. So getting them onto all fours and delivering that way, or standing and squatting, is a really good way to deliver them if there is a reason that there's, you are really worried that something's not going right and baby's not coming out very quickly. And sometimes just that mum's movement helps kind of disimpact and change baby's position a little bit to help get them out. Once the head comes out, so we're not going to go into things like shoulder dystocia and things today, but once the head comes out, usually it's a contraction or two before baby then the rest of the body comes out. It's usually the next contraction. Sometimes there's a loop of cord around the neck, so you just gently kind of release it so it's not there. And then you can just put basically some gentle pressure on baby's head and kind of, again, pull down towards the buttocks a little bit and out to try to deliver the front shoulder, and then the back shoulder will come out, and then the rest of the baby. The cord's there, leave it alone. You don't need to do anything with it. It can stay attached to mum and baby for an extended period of time until you get something decent to tie it off with if you need to. Babies are definitely not my forte. I'm very good at delivering them and then giving them to somebody else. But the reality is unfortunately, you've now got more than one person you're looking after when you've successfully delivered a baby. Congratulations, you've given yourself some more work to do. So look, basically, babies are simple as far as I'm aware. For the first kind of minute or two, which is just stimulate them. So you just rub them up, you dry them. If you've got some, warm towel, I have no idea where you'll get that from on the side of the road, but a warm, dry towel to wrap them in and keep them nice and warm is really important. And then just stimulate them some more. So if they're not crying, more rubbing is always a good way to get babies to respond. Don't forget mum as well. Mum's often going to be cold and at this stage, so keeping her nice and warm, and on mum is the best way to keep a baby nice and warm as well. So getting them on, we call it, which is skin to skin, which is basically get mum's shirt off and get baby directly onto mum or partner or another family member or someone who's there to keep them warm if possible, which is really good. And then the other thing is just you got to make sure that you just keep an eye on baby for the first kind of 10 minutes or so. So they might look really good when they come out and they start to misbehave a little bit and not breathing as well. So again, in that situation, when you're in the middle of nowhere and can't do anything, stimulation is always really helpful. And that's it. Thank you. Oh, I don't know. You stop counting after a long time. That's a good thing about being an obstetrician. I don't have to do it most of the time. I've got wonderful midwives to do that for me, and I just come along and help out when things aren't going that well. So,
any other questions? The microphone to you.
CT scanning in pregnant women.
yes.
As a general question and a general maternal concern.
Yeah. I mean, the general answer is don't. But I guess it's like anything. You have to weigh up, is there a good benefit? And there are a couple of random times where there is a good time to do it. Abdominal scans, there are low dose CT protocols you can do now where the dose to mum, I wouldn't quote me on this, but it's not much more than a couple of x-rays, right? They're particularly useful if you've got someone like with a stone, with a possible bowel perforation, kidney stone, bowel perforation. So scanning here to here, yes, they're reasonable. We do use them for low dose CTPAs as well. The other options are VQ scan, which not all centres have, and I reckon there's an argument every 5 years either way of which one we should be using. But yeah, so can you use them? Yes. Should you do it? Ideally not. Yeah, in most situations the answer is no. Head's usually fine. Lower limbs, upper limbs are fine as well for orthopaedic concerns or neurological concerns.
My question was about the stillbirths.
Mm-hmm.
So if someone has a confirmed stillbirth, what sort of supports are offered? And how long? Is there like a time frame to when they'll deliver?
Yeah.
fetus?
No, that's the problem. So sometimes we find out about a stillbirth because mum comes in labour, okay, usually preterm labour, and it's an incidental finding. But most of the time it's an incidental. We find it incidentally for a scan when they present with reduced fetal movements, for a routine review in antenatal clinic. So they will eventually go into labour, but in the current setting where we see patients, every couple of weeks, most of the time we pick them up before they do that. Once we've identified a stillbirth, and obviously part of that discussion is delivery planning for them, and that's a bit dependent on their history, what gestation they are. Some mums are desperate to get things going straight away, which is completely understandable. Some are desperate to go home and kind of work through the what's happened first before they go through that. And patients are pretty variable on that. But yeah, look, will patients go into labour eventually? Yes, they will, but it usually takes quite a few weeks before they do.
Thanks.
That's handy for me.
Pertains to the earlier speaker, but early pregnancy bleeding and anti-D.
Yep.
What constitutes starting anti-D, like if it's spotting versus, what's the level of bleeding? Sorry.
So that's a good question. So in terms of ectopic and a miscarriage, I would say obviously it's obvious to give. If they're having a little bit of spotting, it does make it tricky. Anti-D is very safe though, and I would think, and you can correct me, but I would think better the side of caution and give rather than not give it, and then potentially they have that flow-on effect of that. So I think it's very safe to give. It's very well researched and tested, so I'd say to give it. It is hard to know though. Later in pregnancy, pregnant women will get anti-D at 28 weeks and at 34 weeks anyway, and it covers them for about a week to 10 days. So if it's within that time frame, it should be okay. But again, if it's feeling a pad, I would say definitely we're going to give the anti-D.
It's more dangerous not to have anti-D than to have the anti-D. So the anti-D is almost a zero issue.
I can give it to you.
Hi, I have actually two questions. First one, what if you are on the side of the road and the baby does not come out with the head first?
If it comes out bum first?
Yeah.
We probably don't have another hour.
Just basic.
The absolute basic thing is just leave it alone. So don't touch it. Ask the mum to push. So it's called a breech delivery, right?
Yep.
It's not very common anymore. It used to be much more common. The general rule for a breech delivery is hands off. So don't touch it. Okay, letting the baby hang. I know it sounds ridiculous. They're hanging by their head. They look like they're hanging by their neck, but they're not. Their head's sitting within the pelvic bone. Is the best way to deliver a breech. So leave it alone. Try not to pull on it. The people who should pull on it are those who have trained to do so, and even then, we try not to if we can help it. So yeah, if bum first, just leave it. Even more hands off than if a head's coming out. Because if a head comes out, you kind of help deliver the shoulders. With a breech, you don't want to pull at all. You just want to let it come itself.
Okay. And the second question, if you have a suspicion of pulmonary embolism to a pregnant lady, it's not a high, like she's not unstable or anything, what kind of exam you perform to be least dangerous for the mother?
Yeah, cool. Yeah, so pregnant women are probably the most thrombotic population around, so they're kind of up there with the most thrombotic conditions. So those APLS patients and things that have clot off all the time, pregnant patients are really common. The SOMAN, so the obstetric medicine guideline, they put out a guideline a couple of years ago, and they keep updating about what to do. Most commonly, PE comes from a DVT, okay? So a lower limb exam, looking for swelling, equal sizes, edema, tenderness, and a plus or minus a lower limb ultrasound is probably the first line. The role of D-dimers is arguable, but there probably is a role for doing a D-dimer. And then if you've got a high suspicion, and when I say high suspicion, it doesn't seem to have to be a high suspicion anymore, then a CTPA is probably the easiest thing to do in most settings to do that. And realistically, patients who come in with no lower limb symptoms, some persistent non-explained tachycardia, and some mild chest pain often will get a CTPA based on much cleverer people than I making that decision. So.
Thank you.
No problem.
Thank you.
Great. Thank you very much.
Thank you very much, Matthew and Caitlin. That was a great way to kick things off. If you are keen to hear a bit more about obstetrics, we've actually got Mel, who's a paramedic and midwife, who's going to be talking on Thursday about a pretty cool thing that she set up for the WA ambulance service. So something to get excited about. But more short term, we're going to take a 5-minute break. Refresh yourselves, lots of food left out there. Grab a plate, grab a tea, grab a coffee, and then we're going to be here soon to talk the law and where that comes in with restraining patients. So quick 5-minute break and we'll get started again shortly.
But these tears I can't hold inside. Losing you within my life, you see. 'Cause you mean that much to me. You could have told me yourself that you love someone else. Instead I heard through the grapevine. Not much longer would you be mine. Oh, I heard through the grapevine. And I'm just about to lose my mind. People say many things from what you see. Son, none of what you hear. But I can't help being confused.
Tick, tick.
Please tell me, dear, do you plan to let me go for the other guy you love? Or don't you know I heard it through the grapevine? Not much longer would you be mine, baby. I heard it through the grapevine. Ooh, just about to lose my mind. Yeah. Honey, honey, I know that you let me go. Said I heard it through the grapevine.
Looking like this, we like to live and let it go. What's gonna do here? What I gotta do here? 'Cause I gotta keep myself free. You're not gonna move, but it's the hide the bruises from all your enemies. I'm in the crossfire, bold, let's come your expectancies. Yeah, yeah. We got nothing to lose. You better run and hide, you cross the line. I got a knife behind my back, just saying. Ooh, we got nothing to lose. You're so God, you be sworn, but what I gotta be people so you can just what you want. If no then you take your judgment, a sense to come home to everything. If you don't conform to what you were born into, then you run the other way. You say, what's your style and who do you listen to? Who cares? Well, the rap is like I'm fake face smiles, got nothing on me. Yeah, yeah. We got nothing to lose. You better run now. You cross the line. I got a knife behind my back. Just saying, ooh, when you got nothing to prove. It's such a God, you be sworn out. But what I got can be caught, so you can just run what you want.
No fire is too hot, no snow is too cold. Youth will never leave me, I'll never grow old. I feel free as a bird. As long as pain, as long as I've got you. If happiness was water, I never run dry. Loneliness was a flower, it would wither and die. The whole world is a private playground. To do what we wanna do, as long as something to think about. I remember when, so tired of being hurt, and I didn't want a boyfriend. Hey, baby, I feel free as a bird, flying around in the balloon. When I think about you,
sometimes I think about you, late nights in the middle of June. He always been faking me out. Can't make you happier now. Sometimes all I think about is you. Late nights in the middle of June. He always been faking me out. Can't make you happier now. Usually I put something on TV, so we never think about you and me. But today I see our reflections clearly in Hollywood, laying on the screen.
Welcome back, everyone. Thank you very much for making it a bit of a short break. It is something that we like to do, is just to move through the breaks quite quickly so you can have as much time with our fabulous presenters as possible. Please, though, don't stress if you do need to get up, stretch the legs, plenty of room in the back of the room, grab something to eat, the toilet, please move around whichever way you feel is working for you. Pretty excited about our next presenter. He's, I think this is the 4th conference he's presented for us. Met him on the ski slopes in Risutsu, speeding down, breaking new land speed records. So we're pretty stoked that he also likes hanging out by the pool. So let's give a nice warm welcome to our final presenter for the day, Dr. Anand Senthi.
Afternoon, everybody. My name's Anand Senthi. I'm an ED consultant from Perth. I work in Perth at a few hospitals and in the country as well, and do a lot of training in the country and some online education. My main website is is edguidelines.com, and at the end of this talk, I will show you a few resources about this topic on that website that I've posted. And so this talk is about restrictive practices. So what do I mean by that? That's basically anything where we restrict a patient's free will. So restraint, including chemical restraint, which is sedation, and detaining patients against their will. And so we're going to talk a bit about the law in different jurisdictions and how it applies to us in our different roles when we actually have the authority to use restrictive practices. And I'm going to give you a bit of a mental algorithm for when to consider the use of it. Then we'll talk a bit about capacity assessment. So that's about decision-making capacity, because almost always we can only use decision-making restrictive practices in patients without decision-making capacity. So our ability to assess that rapidly and make a decision about that is crucial to the decision-making. And then we're going to talk about chemical restraints, so sedation. So I'm going to talk about the different drugs you can use, what are the best combinations, what are the best routes, and the kind of debates about how best to sedate patients, what are good second-line agents, etc. And we'll talk a little bit as we go through about the kind of challenging grey area patients. Now, I got into, and I'll give you some resources at the end. So I got into this because there was a case at one of our hospitals last year, one of our major teaching hospitals, where a guy who was really drunk, totally intoxicated, unconscious, brought in by ambulance into the ED, being kept there for his own good. He then wakes up, wants to go outside and have a smoke. And a code black was called. He was forcibly restrained and pulled back inside by the security. During that time, he was resisting them, and he hooked his leg around one of the security guard's ankles, and he dropped his weight, and it broke the ankle quite badly of the security guard. He was later charged with some assault or grievous bodily harm charge, and the judge instructed the jury that the restraint was unlawful. He just gave that direction to the jury. It was an unlawful restraint, and as a result, the jury found him not guilty. He was basically self-defense because it's unlawful. And that kind of shocked the ED world a bit, because a lot of us thought that was kind of commonplace of what people did, and made us reevaluate the kind of folklore that had been handed down from ED consultant to next ED doctor about what we thought our rights were. And it turned out we were very much wrong about what our rights were. Good question, good tip. Don't ask doctors about the law, because we don't know about the law. So I then decided to start asking lawyers about the law, and I did a big deep dive into this area, and I ended up co-authoring a paper that we published in our Emergency Medicine Australasia journal, and I'll link to that later, which you might find quite useful. And this is what led me down this path, and I've been working with different hospitals in this area since then. So there are lots of areas of controversy in what we're going to talk about. And so definitely consult your local guidelines, protocols, and legal advice. Don't take anything that I say as absolutely true. It's probably true, but don't necessarily quote me. I disclaim all liability for everything I'm about to say. So what, you can tell I've been talking to lawyers. What are restrictive practices we've talked about? Restraint and detention. And why do we do that? Obviously, we do it when lawfully permitted to provide treatment in the best interest of patients, right? To reduce their risk of serious harm, or in some cases, just to reduce their risk of suffering, and I'll mention that in a second, or to reduce the risk of harm to others. And then, in general, and there are some exceptions I'll point out, this only applies to patients who lack decision-making capacity, right? Or what I want to refer to as DMC, or just capacity going forward. And we'll talk about that later. Now, duty of care was often confused by doctors and everyone. We all thought that gave us some sort of authority to restrain patients. And it turns out duty of care gives you no authority to do anything. Duty of care is merely a lawful responsibility you have to basically practice professionally and competently. That's it. That you have an obligation to your patients to competently practice. It doesn't give you the authority to do anything. It's just a civil responsibility. And if you fail in that responsibility, you can be civilly sued. You can be negligent. You can be liable. And so this is just an example of what that is. This is from the WA Civil Liability Act. But back in 2000, the federal government did a big review of civil liability and published this kind of major position paper, which every state in the world, in Australia, basically took verbatim about civil liability, because I don't know if any of you were around back then. There was this time that like charities wouldn't run anything anymore because they were like too worried about being sued. If someone, they couldn't have a school fete or anything because everyone was worried about being sued. So the federal government responded by publishing this new thing, and then all the states, apart from the NT for some reason, adopted this. And there's a lot in it, but when it comes to professional care of health professionals, your duty of care is that you need to act in a way that would be widely accepted by your fellow professionals as competent practice. That's it. And there's other tests if you don't pass that, but there are other defenses, but that's the main one. Now, the key part is, it's okay if an alternative practice that conflicts with yours is also widely accepted as professional practice. You don't have to agree, as long as your practice is widely accepted. And why that's relevant to what we're talking about today is we're commonly faced in all of our roles in that decision is, do I decide to step in and take away and act against the patient's will and restrain them or sedate them, or do I let them go? And that's often a binary decision. And as long as people in your profession would support your decision one way or the other, that's okay. As long as you've taken reasonable steps to find out enough information about the case, about the patient, and assess them reasonably, and then make a call, you don't all have to agree. It's as long as it's widely accepted to let them go or to not let them go, as long as that would be widely accepted, that's fine. So, and here's the key thing about duty of care. You cannot, this is the ironclad fact, you can take this to the bank, you cannot have a duty without a right. It's a prerequisite in the law. You can't have a duty to do anything unless you have a lawful right to do something. So if you don't have a lawful right to restrain somebody, you cannot have a duty to do so. And that's a really important thing to remember. So it's critically important to know what your lawful rights are, because once you know that, then you know what your duties might follow. And even if you have a lawful right to restrain somebody, it doesn't mean that you should or that you have a duty to. You might do so once you've made a capacity assessment of the patient and a risk assessment of the patient. And putting that together, you might decide, like, they don't have capacity, the risk is high, I might then use my lawful rights. But if the risk is low, you might still not choose to use your lawful rights to restrain, because that might not be the appropriate thing to do. And in pretty much every bit of legislation that pertain, and every bit of common law that pertains to restricted practices, it always talks about either using reasonable force or the minimum required force, right? Or acting in the least restrictive manner. So we have to do the least invasion on patients' rights as possible to achieve the outcomes, the therapeutic outcomes that we're trying to do. And the force should be proportionate to the harm avoided. So if there's some minor harm that the patient could come to, and you end up with a 5-person restraint to sedating them and putting them knocking out, and that's not proportionate, right? If it's a minor harm you're avoiding. But if it's a major harm you're avoiding, then it would be proportionate to fully take away their rights and sedate them, etc. And now, you might not have the lawful right to restrain somebody, and most of the time you don't. And that means you don't have a duty to do so, right? So you have no liability. If you have no lawful right, you can have no liability if you choose not to then restrain them, because you have no right to. However, you still might have liability if you don't take other risk mitigating steps. So for example, I work in an ED, I've got a patient who I've assessed or I've not been able to assess, and they want to go home, and I can't keep them against their will because I haven't found that they don't have capacity, I have no lawful rights to restrain them. I still might have other risk mitigating steps I can take, such as speaking to family if I'm allowed to do so, or calling the police and asking them to do a welfare check, or at least explaining to the patient, what the downsides of them leaving are. Like, I still have the responsibility to take other risk mitigating steps, and failing to do so, you could be found liable civilly. And this is interesting that depending which state you're in, there are certain acts like the Mental Health Act and the Guardianship Act and the Consent to Treatment Acts that actually give practitioners legal liability protection if you act within the bounds of the act. So if you make acts or omissions, but as part of the act, as you're trying to say enforce the Mental Health Act or you're trying to enforce the Guardianship Act, you are often given protections from liability, so protections from civil and criminal liability if you act in good faith. It varies from state to state and act to act. It's worth finding out what the case is in your state, because it is even more reassuring and gives you more confidence in your practice knowing that you're protected if you act reasonably as part of the acts. So let's talk about the law. So there are obviously 8 different jurisdictions in Australia, 6 states and 2 territories. And there are some common themes we'll talk about and a few differences we'll talk about. But we can't obviously get into the nitty-gritty details because they are quite different in each state. If anyone here works in WA, I know that legislation like the back of my hand now, but I don't know every bit of legislation in Australia like the back of my hand. Now, the common law is the same everywhere. So there's certain rights, like the doctrine of necessity we'll talk about, that's inherited from UK law and is the same across all of Australia. So there's two things to think about in terms of restricted practices. What are your lawful rights to use restricted practices? And then, if you don't have a lawful right, do you have a lawful defense? And a lawful defense is when you decide to basically assault somebody or commit a crime such as deprivation of liberty or assault, and your defense in court will be one of these defenses to say, Your Honor, this is not actually an offense because I've got one of these lawful defenses that protect me from being charged. So it's not actually a lawful right, but it's a lawful defense. And it's useful to think about it that way because the lawful right is the thing that gives you a right. And I would not rely on a defense very often unless it's very clear that that defense applies. And we'll go through those defenses. Now, who is generally empowered by the law to restrain? Well, generally it's doctors most of the time and anybody assisting the doctor. So a doctor and usually nurses or security guards who are assisting that doctor are then authorized under that legislation. Ambulance officers and paramedics are authorized in certain ways, in certain times, in certain jurisdictions, and we'll talk about them a bit later. Ambulance officers frequently get their authority by assisting police, but sometimes ambulance officers have their own authority, particularly under mental health acts, to use restricted practices. So the first act I'll talk about is each state has a combination of either Guardianship Act or Consent to Treatment Act, or both. And these usually deal with, a lot of the act is about dealing with patients who have chronic lack of capacity and they've got a guardian appointed already. But part of the act is often to do with anybody, like anybody in this room, any human. If you temporarily lack capacity, the act speaks to that as well, and it speaks to what rights we have to treat that patient without consent if they temporarily lack capacity. Usually they're referring to medical treatment, not psychiatric treatment, because they generally defer to your mental health acts for psychiatric treatment of patients. This is an example, this is from the WA version, but it's common in about 5 states, is what they refer to as urgent treatment. So several states, and I'll show you which ones, have this urgent treatment provision either as part of your Guardianship Act or part of your Consent to Treatment Act. And it's with a patient who lacks, that you've assessed to not have decision-making capacity, which again we'll talk about later, what that means. You can provide urgent treatment without consent to save the patient's life, obviously, to prevent serious damage to the patient's health, or to prevent the patient from suffering or continuing to suffer significant pain or distress. Now that last one, C, is actually quite a low bar for what you'd be able to use restricted practices to be able to treat this patient, without consent. It's probably the lowest bar of all of the acts we're going to talk about. So it's worth knowing, I actually think this is what empowers us to use restricted practices in most of the time that we choose to do so. And I would say the most common time that you're using restricted practices, and you don't think you are, is your elderly 70-year-old patient with urinary sepsis who's confused and you can't let them go home, right? Because if they go home, they're probably going to die. And not now, probably not in the next few hours, but probably in the next few days, they will die if you don't treat that urinary sepsis, right? Or that severe renal failure, or that severe liver failure, or whatever it is that's causing them to be delirious, right? And we don't end up sedating them very heavily. We often just, lightly restrict their movement from leaving the hospital, keep them inside their bed, may occasionally give them sedation, but it's usually very light touch restricted practices, but they are restricted practices. You are infringing on their rights, and you're doing so because we are authorized to do so, and primarily by Guardianship Acts, and primarily by these urgent treatment provisions in the Guardianship Act. That's what's mostly giving you that protection. And the states that have that, those are I might have this wrong, but this is on my reading. WA, Victoria, Northern Territory, New South Wales, Queensland, and Tas all have these urgent treatment provisions in their acts. And the states that I'm not sure if they do, is anyone a doctor working in the emergency department in the ACT here? Damn. But in the ACT, I could not find any specific urgent treatment provision that gave you the same authority, which makes me think that unless it's a mental health problem, you're relying mostly on the doctrine of necessity, and that's a big problem. And we'll talk about, because that doesn't give you much rights at all, in my view, and in the views of lawyers I've spoken to. We'll get to the doctrine of necessity. But in South Australia, you've got what is similar. It's called the emergency treatment provision. But if you look at the definition of that, you can treat somebody and give them treatment that is necessary to meet an imminent risk to life or health. And that opinion has to be supported in writing by a second practitioner who has personally examined the patient, right? Now, that's a higher bar than urgent treatment for pain and suffering, much higher bar. So I actually think that's that gives you less rights. Because again, that patient, that 7-year-old patient with urinary sepsis, I don't think that's an imminent threat to life. They're going to die in the next few days. That's not imminent in the terms, legal terms of imminent is like right now, like very soon. So I think that's problematic. But anyway, again, consult your local practices, consult your local guidelines, but that is of concern. Now, the use of force. Can you use force to give that urgent treatment? This is an area of debate. Most of the legal opinions that I've spoken to, the answer is it's implied that you can. Because if you are to treat someone against their consent, no matter what it is, if you apply a bandage, if you put an IV line, any touching of their body without their consent is the use of force in the eyes of the law. So if this act is saying that you may treat this person without their consent, it's implied that is using the minimum force required to do so. That's the legal opinions that I've received, and that's, I think, how we've essentially all practicing, is that we use the minimum force required to treat without consent. Queensland has done the right thing, I think, and specified in the Act itself that you can use the minimum force required to treat without consent. But the other states haven't done that, so it's just up to lawyers to interpret. There is supportive case law as well, particularly in WA. There was a state administrative tribunal where they specifically said that urgent treatment means that you might need to sedate somebody, you might need to restrain somebody if it's in the provision of treatment. So there is case law to support that as well. So that's the Guardianship Act, which I think we're probably using the most when we restrain or detain patients. Then you've got the Mental Health Acts, right? And these obviously differ from jurisdiction to jurisdiction. And it's where we get to restrain patients, or where that becomes part of our work, is when we're considering some level of involuntary treatment for that patient, right? And what you call that and what form you use, all that differs from in every state. But it's when you're going to say, I'm going to treat you against your will in some way, either to examine you or move you from place to place, or to treat you or admit you. That some sort of involuntary care is when we have to use reasonable force to do so. And it's empowered in every single act in different conditions. So it's important that you know the fine details, because this stuff is unfortunately complicated. And the reason it's complicated is because the legislature, like your parliaments, when they've enacted these acts and then reenacted and re-amended these acts, they are doing a complex balancing act between the valid rights of patients to not be stuck in asylums for years and years, or months and months, or even days and days unnecessarily, versus the need to treat patients who are often lacking capacity, at high risk of themselves, and need that treatment, and they don't have any insight into that problem. So they're trying to balance those risks, and it leads to complicated acts and complicated balancing. And so you need to know what your powers are for your role in your state, and we'll talk about some of those things, but I won't be able to give you every bit of detail, and what criteria you have to fulfill to be able to make somebody an involuntary patient. A lot of doctors don't know the criteria well, and I'll give you an example of a key bit of criteria that is absolutely essential that a lot of people don't know. And then what areas and places and settings that force is authorized. So, for example, in one state, in my state, there is this problematic loophole that if you refer to somebody under a form to be assessed by a psychiatrist, right? If you refer them to a hospital and they're already in that hospital, or they've arrived at the hospital, yes, you have the right to restrain that patient in order for them to have that examination by a psychiatrist. But if you refer them to another hospital, until they arrive there, you don't have the right to restrain them, which is utterly absurd. So, and when the transport order arrives, they can restrain them and they can transport them. But until the transport arrives, you're some small country hospital, you lawfully can't do anything unless something like the doctrine of necessity applies. The Mental Health Act doesn't give you any rights to restrain them. It's absurd. And through ASIM, I've raised this directly with our minister, because it is a problem, massive problem. And there's another couple of loopholes and problematic areas of our act. But so you need to know your act. You need to know when, in which situation you can actually use force. And then whether an intoxicated person can be put under Mental Health Act. This is a common question. In almost every act, they'll have a thing, the little section saying these things are not by themselves a mental illness. And it'll be like, religious beliefs and this, or being, one of them has being eccentric, which I thought was quite good. And so, which I'm glad, because sometimes I'm eccentric. But anyway, and they all mention intoxication with drugs or alcohol. So that by itself doesn't form and isn't a mental illness, and you can't use the Mental Health Act for somebody merely because they're displaying features of intoxication. However, if, despite their intoxication, you believe there is an underlying mental illness, you can generally still use the Mental Health Acts. I think there's a better way of going about that than using the Mental Health Act. I think the Guardianship Act is better to use in that scenario, and I'll give you an example as to why. This is where you have an urgent treatment provision. If you're an ACT, I can't help you. But in most of the other states, I think there's a better way of going than using the Mental Health Act. And the other reason I don't think we should use the Mental Health Act willy-nilly, apparently, I'm told, it can affect patients down the line, like getting insurance and things. When you try to get life insurance or income protection insurance to say, do you have a mental health problem? Yes, no. Have you ever been admitted as treated as an involuntary patient? That's often a question that comes up. And by you using those forms and making them an involuntary patient, it affects them down the track. So I don't think they should be used willy-nilly. But when there may be a better alternative. And the last thing is decision-making capacity relevant? This is really interesting. So in 5 states, you can only put someone under the Mental Health Act for involuntary treatment and care if they lack decision-making capacity. This is commonly unknown to people. They must lack decision-making capacity. Now, to be clear about what that means, a lot of mental health patients, particularly the suicidal patients, like psychotic patients almost always don't have any capacity. But people who are suicidal, you can often have very reasonable conversation with them, and it might not be obvious that they lack decision-making capacity. And the key thing about decision-making capacity is it's both decision and time-specific. So a person with severe depression and high suicidality might have complete decision-making capacity about whether they wish to have treatment for a coexistent pneumonia, or how they want a toilet, or whether they want to have an indwelling catheter, or whether they want to have analgesia. They might have complete capacity for those decisions. But their suicidality and their depression might be so severe that they lack capacity to make mental health decisions about their mental health treatment. And that is essentially what you must be arguing if you believe they can go under your act. Because you must believe that they lack the capacity to make mental health decisions about their mental health treatment, or you cannot put them under the Act. And I personally think that gets fudged a bit, and people who probably have capacity are being put under the Act. But you must have that belief before you can put on the Act. And equally, if you do not have that belief, and you can justify as to why you don't have the belief, you can argue as to why you don't put them under the Act. And I'll talk more about that in a second. But in those 3 states, Northern Territory and New South Wales, it doesn't appear that you need to lack capacity. And it means that a person with capacity, as long as their risk is high enough that you're sufficiently concerned, you can still put them under your Mental Health Act, apparently. And so I'll give you an example. Northern Territory says in its criteria that the person is not capable of giving informed consent, i.e. lacks capacity, to the treatment, or has unreasonably refused to consent. Now, unreasonable refuse is basically of no value, because the courts have been very clear. If a person's decision seems unreasonable to you, that's irrelevant. Your opinion on reasonableness is largely irrelevant by itself, because people make lots of decisions that make sense to them and you think are quite stupid and quite ridiculous, but that's okay. As long as they have decision-making capacity to make a decision, you have to accept that generally. So just because it's an unreasonable decision doesn't mean they lack capacity. So for my reading, the NT one, patients who have decision-making capacity can be put under your Act. Victoria, it says when a patient does not have capacity to give informed consent or does not give informed consent. So basically, everybody, right? So you don't have to have a lack of capacity. And New South Wales, I could not find capacity mentioned anywhere in the Act on my review. So I think there are 3 states where capacity may not be relevant, but in all the other states, you need to find a lack of capacity for their mental health treatment before you can put them under the Act. Now, every Act has a least restrictive principle, and for very good reason, right? That we should not restrict mental health patients' rights unless we really have to. And everything we do to them should be the least restrictive version, right? That means if we can manage them in the community, we should. If we can't and we need to manage them in the hospital, it should be voluntary if we can do it voluntary. And only if we really can't do it voluntary, then we do it involuntary. And only if we really need to sedate them and restrain them, should we do that, right? That's an absolute requirement. If you look at all those different descriptions, they all, for each of those states, have some version of the least restrictive principle. Because this is, again, that balancing of rights, right? Of patients' rights. And so you are required to do so. And this is critically important. There is a High Court case where, I think it was from New South Wales, from memory, where a hospital psych reg assessed, like mental health team, assessed the patient in ED, decided it was reasonable that they should go home with their family and have care in the community, considered that in this situation with the risks that had presented themselves at that time, that was the least restrictive manner, and that to admit them would have been excessively restrictive. So they made that decision. that person then went home, and I think they then killed somebody in the family at some point. And that family then sued the health department. I think the health department lost and were found to be negligent. It went to the High Court, and the High Court actually found in favor of the health department. And one of the points, there was several points, one of the points they said was there is a lawful requirement for doctors and mental health professionals to act in the least restrictive manner. And that's not a no-risk scenario, right? If you do that, eventually somebody will die. They have to. If you want a zero death in the community, then everyone must be admitted. And we don't want to go back to those days. And that's why these are part of our legislation. So the court accepts that finally somebody will die. That's going to happen. And if we punish the doctor every time that happens, then they will no longer be able to comply with the act and act in the least restrictive manner. They will have to admit everybody, and that will be in contravention of the law. And therefore we find the state is not liable. So this is a critically important decision that supports the fact that you must act in the least restrictive principle. And again, as long as you make a good assessment, you get in collateral history, you do all the things that you should do, if at the end of the day you decide that it would be excessively restrictive to admit this patient or involuntarily treat this patient, then you are supported by case law. And of course, if you're not sure, get a second opinion, get people who are better than you. Like I try to get the psychiatrist to do that for me because I don't do that all the time anymore. But somebody needs to make that decision who's well skilled and get as much help as you can. But if that decision has been made, you are supported by case law. Now, here's the interplay between those urgent treatment provisions of the Guardianship Acts, which was presented in 5 states into a tighter version in South Australia, 5 or 6 states, and the Mental Health Acts. Okay, and this is how I read it, and how I practice, and how a lot of my colleagues now practice. Let's say you've got a person with meth intoxication. So recently used meth, like today or last night or very recently, and came in and they show signs of psychosis, it's like psychotic features, but they probably seem to be also under the influence of methamphetamine currently, right? This, now, you have an option. If you think underlying this is something called drug-induced psychosis, you have an option to use your involuntary sections of your Mental Health Act. You have that option to you. But I generally think that's not the best option. And if you're in the ACT, that might be your only option. But everywhere else, I think if you've got an urgent treatment provision of your Guardianship or Consent Act, that's a better option. Because methamphetamine intoxication, including all its side effects, such as psychotic features, is a toxicological problem. And toxicological problems are medical problems. They are not psychiatric problems, and they are covered by these Guardianship Acts, and they require urgent treatment. And so you can use the urgent treatment provisions to treat this person without consent. That urgent treatment is sedation and a therapeutic sleep. That is the treatment for that condition. And once they've had that therapeutic sleep, and they've woken up, if they're back to normal, they're not psychotic anymore, see you later. Take other risk mitigation steps, get your drug and alcohol involved, etc. But there's no need to restrain them anymore or sedate them anymore. But if they wake up and they're still psychotic 12 hours later and the meth has worn off, now you have a new diagnosis, which is drug-induced psychosis, right? You had methamphetamine intoxication with psychotic features, which is a toxicological problem. Now you don't have any meth intoxication, you have a different diagnosis. You have drug-induced psychosis. That's a mental health problem. That is a Mental Health Act. And so if you need to continue to restrain them at that point, and then you'll need to use your involuntary sections of your Mental Health Act. So that's how I see the interplay. And I think you could do that with a lot of other conditions as well. That if you think it's actually an acute medical or toxicological problem, then I prefer not to use the Mental Health Acts because I don't think you need to, and it has downsides to do so. Sudden or extraordinary emergency, I'll mention this briefly. I don't think you should rely on this, but in fact, I think almost all, most states, I couldn't find in Tasmania and New South Wales, but most states in your criminal code will have a defense that you can use called a sudden or extraordinary emergency, that if there is a sudden extraordinary emergency in your life, that basically compels you to break the law to meet the needs of that emergency, that is a defense in court. So for example, there's a true emergency, someone's dying, they've got to get to the hospital, no ambulance is available, and you drive them to the hospital and you break the speed limit because it's literally time critical that they need to get there quickly. And you could use that as a defense in court against that speeding ticket. Right? If you had some other emergency, there was a bushfire, and you had to, or let's say someone was chasing you and you fear, like literally chasing you to kill you, and you fear for your life, and you had to therefore trespass into other people's houses to run away from them, break into someone's houses to get away from them, whatever, that might be a defense that you'd use, right? A sudden or extraordinary emergency, I had to break the law because of the emergency. From the advice that I've got, this is often quoted as something we can use. I don't think we should. The advice that I've got is that most of the scenarios that you would envisage in the ED or in the ambulance service or where you work, where a patient becomes agitated and aroused, that is not a sudden or extraordinary emergency to us. That is the routine part of our healthcare, and we have to have processes and procedures for it. And the analogy is, a fire is not a sudden or extraordinary emergency to a firefighter. So they would not be able to use a defense. Oh, I had a fire. I was authorized to do this and that and the other. No, you're not. That's your job. So I don't think we should be using this either, unless something truly sudden and extraordinary comes into your emergency department or ambulance that you don't deal with on a frequent basis. Maybe then you'd be able to use that as a reason to break the law. But I generally don't think this has got any validity. Self-defense has high validity. Every criminal code in the land has a self-defense provision, and if you feel a threat to your being, your physical threat to you, a significant threat to you or somebody else, you have the right to use force to prevent that threat. Right? And that means to not just patients, but staff, family members, other visitors, whoever it is, you always have self-defense rights. But of course, you must act reasonably, right? The amount of force used must be reasonable to the threat that is. And a lot of the states have things like you can use force to protect property, but for property you can use a lot less force. Like if you kill somebody to protect property, that generally will get you manslaughter, right? But if you kill somebody who's trying to kill you to protect actual life, that's different, right? So it's all got to be reasonable to what the threat is, and it's to person or property. So don't forget self-defense, but remember, self-defense can protect you. You can use that to protect you or somebody else, but not the patient themselves. So it's not for you to go, oh, yeah, you're about to harm yourself, I can use self-defense to protect you. No, you can't. It's to protect you or somebody else. Doctrine of necessity. Now, this is very important, but I think is probably overly used excessively, and it's only because it's not been tested in court in the medical sphere that people probably overuse it. And one day it will be tested, and we'll find out whether we're overusing it or not. But the doctrine of necessity is a common law principle, so it's in no legislation anywhere. It's come from the UK courts into the Australian courts, and it's accepted as a part of our law. It's common law. And so it is the idea that you can use it as a defense against both civil liability and criminal charges, such as assault, trespass, deprivation of liberty, false imprisonment, all those things that you would be charged with normally if you decide to hold someone against their will or sedate them. You can use it as a defense against doing so in court in situations that kind of basically have to fulfill these three elements. This is kind of advice from the Chief Psychiatrist's counsel, the lawyer for the Chief Psychiatrist WA. And it was that your restraint was done to avoid an irreparable evil, such as imminent peril to life or serious injury, to that person or somebody else. And that person carrying out the restraint believes that there's basically this idea of imminent peril. There has to be imminent peril. And the restraint again has to be proportionate to the harm or the evil avoided. So this is often wrapped up into this term, imminent risk of serious harm. Right? There has to be an imminent risk of serious harm for the doctrine of necessity to apply. Now, the lawyer, when she talked to us about this, she gave examples like, I'm talking like someone's about to step into front of a car and then you grab them and throw them to the side. Or someone's about to jump off a building and you grab them and you pull them down and restrain them. Like, that's the kind of imminence that she was referring to. That's the kind of imminence that they referred to kind of from common law cases outside of the health environment. And we're trying to apply this within the health environment. But this kind of concept of imminence still applies. It needs to be now. Right? If someone's going to die in days, that is not an imminent threat. It's definitely not an imminent threat. That would not be doctrine of necessity. Maybe hours. It was like absolutely sure this person's going to die in the next couple of hours. You might be stretching it to use the doctrine of necessity. I think that's probably stretching it. But the idea is imminent risk of serious harm. And there aren't that many situations that we have that I think fulfill the doctrine of necessity. And I think it gets overused. And it hasn't been tested, and maybe it never will. And the reason that a lot of these things don't get tested in court is because, firstly, somebody would have to sue you, and so be very upset with the fact that you restrained them and sedated them, and then actually sue you and actually win, and that you didn't have a defense under either the Mental Health Act or the Guardianship Act or something else already. And the reason so this is if you want to use it as a defense against civil charges, but if you want to use it as a defense against criminal charges, you need to have a prosecuting authority in your state that has an interest in prosecuting you. And it luckily turns out that most of our prosecuting authorities don't have an interest in prosecuting doctors and ambulance officers and nurses for doing their job and looking after patients. So it has to be fairly egregious before someone gets prosecuted. So even in that case I told you about in the hospital in Perth, where the drunk guy got restrained, blah, blah, he was getting charged, remember? Right? He was getting charged, and that was his defense to his charges, but that it was an unlawful restraint. But since then, to my knowledge, there's not been a civil case that I'm aware of that he's been successful against the hospital, and because all he lost was a few hours of his life. He got sedated and he woke up and he went back on his merry way. So there wasn't a lot of loss for a civil case, and the prosecuting attorney in the DPP in Perth hasn't decided to charge the security officers or the doctors with assault or deprivation because no one wants to do that, right? So that's why, if you're acting in good faith, you're generally okay, but that's not a reason to breach the law. It's still a reason that you should act within the law, but that's probably why this hasn't been tested, and we don't know yet what the courts would say about what imminent risk is in a healthcare setting. We talked about that already. So this is the flowchart in the article that I co-authored in Emergency Medicine Australasia. I don't know how well you can see it, but it's a flowchart for when to consider restrictive practices. Now, let's start with... It starts with this idea of, does the person have capacity to make a healthcare decision? And it would be better if it actually said to make a specific healthcare decision, because remember, capacity is decision specific, right? And if the answer and so it depends on what you're asking the patient to do, or what you're proposing as treatment, or what they want to do. So they might want to say, I want to leave. So the decision there is, I want to leave the healthcare facility. And then you're thinking, do they have the capacity for that decision, given the risks, etc., of that decision? And so if the answer is yes, they have capacity, over here, yes, then generally, as long as you're not in one of those 3 states where capacity doesn't seem to be relevant, if you're in one of the other 5 states where capacity is relevant, then you have to respect their wishes, right? So if they've got capacity, that's it. Game over. There's no restrictive practices can be used, but you need to take other risk mitigating steps. Yeah, and offer them alternatives, right? So, for example, you want to admit someone to IV antibiotics, and they go, I don't want to come in, I want to go home. That's not okay for you to go, well, screw you, you don't listen to me, I don't like you, get out of here. The answer is, okay, here's some oral antibiotics, right? You should offer them the next best thing, right? Don't get cut, don't get upset, just offer them the next best thing. Don't take it personally, right? People don't have to listen to you. So that's, but in those 3 states where capacity isn't relevant, then you might still be able to put them under the Mental Health Act if they fulfill the criteria, right? And that's where that would happen. But most of the time, when you're thinking about using restrictive practices, it's in the no section, right? That do they need treatment for physical illness, injury? And I won't go through every arm of this, but part of the arms here was just to tell you there are common law rights, there are self-defense rights that you can use, etc. But the main thing it leads to here that I want to point out is, do they need treatment? If the answer is yes, and if they object to treatment, yes. Is the treatment urgent? Yes. Then usually you have a guardianship or consent to treatment act that has an urgent treatment provision in it where you can treat them. And in all of those cases, you can treat them now, but as soon as practical, you're meant to then speak to their next decision maker, which is usually the next of kin. If they've got a guardian, if not the next of kin, and then down the line of the hierarchy of decision makers. Now, this is the hard part. The person, not yes, not no, but I'm not sure. Right? I'm not sure if they've got capacity, right? In general, if you're not sure, they do, okay? And I'm going to come back to that in a bit. Now, if you're worried, if they've got serious risk factors that you think they might not have capacity, there is an argument in a couple of papers by Eagle and Ryan that says there may be a amorphous common law power that you can temporarily hold them to assess them, but it has not been tested. It's just an argument by a couple of people in a couple of journals. I don't rely on it. So, in general, if you're not sure about capacity, then they have capacity. And the reason is that by law, everyone has capacity, right? There is something called the lawful presumption of capacity. Everybody who's 18 has. Okay, so everybody who's 18 in Australia has a lawful presumption of capacity. So until you can what's called rebut that presumption, until you assess them not to have it, then they have capacity. And that's the law in Australia, and I think in any common law jurisdiction. So, and that's very important to understand, and we'll get to how you might have to navigate that. So, for ambulance officers and paramedics, so most of what I've talked about is for doctors and people assisting doctors, which could be a nurse, could be a security guard, could be an ambulance officer who's in the ED assisting a doctor. But if you're in your field, in your area, without anyone else, then you have to think about and know what acts might be affecting what you might be relying on. Sometimes, and often, it's a doctrine of necessity that you might be relying on, perhaps overly so. Sometimes you are empowered because you're assisting police, right? So you've called the police to assist, and you're now assisting police, so you're empowered because you're assisting police. But you may be empowered by specific acts. So the most common is the Mental Health Act. Most mental health acts have a provision where ambulance services, they say, it usually refers to ambulance services. So you could be a paramedic or an ambulance officer, but the ambulance services, they have some sort of powers within the act to take somebody somewhere, right? To take them to an ED or to an authorized mental hospital. So you should know your own state's legislation. Oddly, there's some controversy about New South Wales, Victoria. There are arguments as to whether it really does give you the right to restrain patients. My understanding is everyone acts as if it does, and it hasn't been tested, so, do as. But in WA, there is no specific provision where it refers to ambulance services, and that might be because it's a private ambulance company, the only state where we have a private ambulance company, and so they didn't put anything in there for some reason. So in WA, you may be more often relying on the doctrine of necessity, which I think is a bit of a problem. I'll come back to that in a second. But in Northern Territory and South Australia, when I looked at your Consent to Treatment Act, or your Guardianship Act, I think it was Consent to Treatment Act, in the definition of a health professional, I think ambulance paramedics fit in, because now you're regulated and registered with APRA. It referred to like health practitioners as regulated in the law. So I think in those states you might be included as health practitioners and therefore have the urgent treatment or emergency treatment provisions of those states. Again, check your states. Just bring it up for you to have a look at. But in most other states, they didn't include ambulance officers or paramedics in their health practitioner when they wrote those acts, because most of those acts were written before ambulance officers or paramedics became registered health practitioners. Now, the top one. So let's say you're in WA or you're in any other state and it's not a mental health problem and you're not sure if you're covered by any consent to treatment acts. You're probably not, except in those states, maybe. And so you're mostly relying on, your elderly 7-year-old urinary sepsis patient. You're probably relying on the doctrine of necessity, right? Which I don't really think it stretches for the person who's going to die in a few days, right? So it's tricky. I actually think it's a tricky situation. There are civil and criminal protections in a lot of your states for you doing your job in good faith, and I think that's what everyone tends to rely on. But it is an argument as to whether a lot of the times that you might choose to restrain or sedate somebody, whether it fits the doctrine of necessity or not. Now, I've mentioned there that once you've got a patient within your ambulance and your ambulance is moving, I think doctrine of necessity steps in a bit higher, because now you've got a much bigger threat if somebody becomes unruly and violent or wants to jump out of the ambulance. Suddenly, the doctrine of necessity, there's a clear imminent risk of harm to either you or themselves. So I think doctrine of necessity takes a much bigger role once you've got someone in a moving ambulance. But once they're in their house and you just come in to see them, I don't know, I think it's probably pushing it to be using that a lot of the time. And I'd be more inclined to call the police and then rely on their powers and assist them. But, I don't want to change your practice. I'm just giving you some points to think about. Capacity. So that was all the stuff about the law across 8 jurisdictions that we just covered quite quickly. Does anyone have any questions about that in your role or in your state before I move on to rapid capacity assessments? Yes, I'll start with you. Sorry. So can you speak a little bit louder? Yep. 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 Yeah, so that is tricky. What I would say is generally no. Generally, the Mental Health Act is only for mental health treatment. But you can usually use your Guardianship Act or whatever other act to give urgent treatment, because that's a medical need. They have a medical need of urinary retention and need treatment. So it's usually that. So yes, so that's a good question. And I think more it's the other side. Yeah. Yes, someone over there. Yes.
For us nurses that work in remote areas. Now, you've just given me a lot to think about.
Yeah.
I'm quite often the only nurse at work by myself with a psychotic patient. No police. We have a security guard with us occasionally. That's a very grey area that you've given us to think about now.
Well, before I spoke, what would you have done?
I would have called RFDS and got a order for sedation.
Yep, okay. So that's still possible, right? But I'm just thinking, which state are you in?
WA.
Oh, right, yeah. So, so you've got ETS?
No, we don't because we're too remote. We don't have the internet during the wet season.
Oh man, that sucks. Okay,
Exactly.
so you don't have ETS, but you do have RTS, and RTS have a doctor, right?
Yes.
Yeah, so you'd be liaising with them and making an assessment in joint with the doctor, and the doctor would have rights under the Guardianship Act to provide urgent treatment to that patient if you thought it was not psychiatric, if it was meth intoxication with psychosis, or just somebody who's behaviorally disturbed, when you think it's a medical cause, they've hit their head, whatever. Guardianship Act urgent treatment provisions are pretty clear. If you think it's mental health, then in conducting with a doctor, you could use the Mental Health Act. So you've got powers if you think the patient lacks capacity.
Yeah, sorry,
and
but
needs treatment.
sometimes it's a bit grey because what happens in communities like where I work is sometimes you don't know for sure and you're just going by what the family's saying.
Yep.
And then that becomes grey. Another thing I'd like to just ask you is just recently, actually, it's the first time in my nursing career that I actually heard of the doctrine of necessity. The story, I won't try to mention any hospitals involved or anything, but I had a patient ring up saying that they had chest pain to the hospital where I was. He said that he had tried to get the nurse on call to answer the phone. Hadn't. We looked up this patient. They'd only got out 2 days ago from the hospital and were awaiting a major operation for a heart. The next thing, we rang and got hold of this nurse in this community, and it had then somehow within a half an hour turned into he's now sedated on a bed and we're bringing them to you. And we said, under what conditions? Because this person had a heart condition. And they said, oh no, it's mental health and it's now the doctrine of necessity. And I'd never heard of it until then. And we were just very confused because it was a chest pain that somehow went awry. And when we started asking questions, they said they're no longer coming to our hospital and were bypassing us and going straight through to another hospital.
So, yeah, it's a good case. So, when I show you the resources at the end, and one of the resources is that article that I co-authored in a major journal, it has 5 case examples of situations, and then the answers at the end that the lawyers felt were the answers, and we agreed, depending. The one is very similar to this. A schizophrenic patient who's having chest pain, is having an MI and doesn't want treatment. And in general, if they've got capacity at the time, you can't enforce treatment. But they did have a lack of capacity to enforce treatment. And you would have an imminent risk. So if you had chest pain by itself, it's arguably not imminent. But if you have a strong belief that it's a heart attack, then it would be arguably an imminent risk. You could stretch that to that, I think. And then if they had lack of capacity, you could treat them. So, but if they had capacity, right? If they're me, and I'm like, I don't believe in your Western medicine. I don't want treatment for heart attack. That's not an indication for you to sedate them. That you just have no leg to stand on. They need to lack capacity. And that's the hard part, is making the capacity system. And it's just sometimes you can rely on collateral. It's fine to rely on collateral, but you generally in most situations have to make some assessment yourself and combine that with your collateral to come up with your assessment of either risk or capacity. And it is tricky. And what I would say to you is, if you're in situations where you're not sure, take all risks of getting steps you can, but if you're not sure, then you have no lawful right and therefore no lawful duty. Right? The patient has capacity until you've shown otherwise. So, and many times, like I do this all day, right? We have patients coming in all day with capacity questions about them and whether we're going to keep them or not. And I've got good at it from experience, right? But it's still tricky sometimes, right? To decide whether they've got capacity or not. And until I've completed my assessment and become confident that they don't have capacity, they do have capacity. There's nothing more ironclad in the law than that. And so whether you would choose to rely on some flurry of very amorphous common law rights to maybe hold them temporarily to assess them, I don't, because I don't believe those are actually parts of the law. I don't know if they are true. So if I don't know that they don't have capacity, if I can't assess that as a doctor and make that assessment and write that down and document that and stand by that, then they have capacity. That is the law. Any other questions about any of that stuff? Oh, yes.
I know you said that the doctrine of necessity hasn't been tested. Is there anything in the literature, I don't know if you would know, you don't know all the literature, but where the doctrine of necessity not acting under the doctrine of necessity has led to an issue? I'm WA as well, paramedics. hand up and people can say if I'm wrong here. We've probably not been very good at teaching this to our paramedics, and we've relied a lot on in the past of the Mental Health Act, and we are taking people in against their will under the Mental Health Act, but we've had good relationship with WA Police in the past. There's a bit of an issue at the moment where we're not getting call-outs, and so there's a lot of things that are happening that potentially we're saying it's under the Mental Health Act that it doesn't actually fall under the Mental Health Act, or in the past we've been able to say to people, oh, well, if they're not under the Mental Health Act, but we're unsure at the moment if they have capacity because we've spent 2 minutes with them. They're normally drug, alcohol affected. We've said to them in the past, if you want to jump out of my ambulance, then off you go, bye-bye. But technically under the doctrine of necessity, if they are requiring treatment, then we have the right to take them in. But a lot of the time, because we've relied on the Mental Health Act and now we're not having police, a lot of our paramedics wouldn't do that.
Yeah. So what I would say is the reason I broke that up into lawful rights and lawful defences is, in general, as I understand it, if you don't have a lawful right, then you can't have a lawful duty of care. Yeah. Right? It's inexplicable to be expected to rely on a defence when that's not clearly defined. Right? So I think you'd have very little risk of liability if you chose not to restrain somebody, if you didn't believe and know that you had a lawful right to do so. Like saying, oh, you should have relied on doctor necessity. That's not a thing. That's just a defence. That's something that you get charged in court and then you go, oh, Your Honour, this is my defence. Right? That's not a lawful right. That's a defence. So I make it very simple when I train people is, do you have a lawful right or not? And in most states, it's Mental Health Act or your Guardianship and Consent Act. If you don't, then you don't. That's it. Now, if you choose to still act and restrain or use restrictive practices because you believe you want to use the doctor necessity or something else, I mean, self-defense, that's pretty obvious, but if you want to, then that's up to you. Yeah. But no health jurisdiction can tell you to do so. No one can tell you to commit a crime and then go to court and use that as a defense. No one can do that. And no one would seek to do that. So, well, they might, but they're idiots if they are, right? And you can tell them to screw themselves. So, because you can only act within the law. There's nothing special about us. We're just people who have to act by the law. There's nothing special when you got trained that gave you rights to not act within the law. So if you have a lawful right, then do so. If you don't have a lawful right, let them go. And take other risk mitigating steps. That might be getting their family members or whatever. And as you say, most of the time, even in the Mental Health Act, you need the police to use their powers because they've left WA ambulance out of the Act, which is a real problem.
At the moment, the working paramedics on road because they don't know where their responsibility lies of this patient who clearly needs assessment, but police have refused to come.
Yep. And
they're getting into some silly little grey areas of having to physically restrain people and do other things because to stop them harming people. Or,
yep. So if there's an imminent threat to somebody else, that's fine. That you've got self-defense legislation, right? Now, many would argue, some lawyers have told us that self-defense legislation generally allows you to immobilize somebody, restrain them, and call the police. It's unclear whether it allows you to then treat them, right? In fact, it definitely doesn't allow you to treat them. But, I know in the WA legislation, it says you can use a reasonable response, right, in self-defense. In an ambulance, a reasonable response might be actually sedation, right? If they're going to harm somebody. I would argue that it is, and that would be something that you could then use self-defense legislation to protect you and others. So don't forget self-defense. And funny enough, in WA, I couldn't find this in other criminal codes, but the self-defense legislation, it talks about a threat to you or others, and it specifically says, and that threat does not have to be imminent. So if someone says, I'm going to go home, I've got no mental health disorder, I've got no treatment needs, but I'm going to go home and I'm going to kill my wife. I can restrain them and I can hold them until the police arrive. And it would be, the police will come to my hospital pretty quickly. It'd be arguably unreasonable for me to sedate them for 8 hours for that response. I should just hold them until the police arrive. I've got security, etc. But you're in a different scenario, and a reasonable response to your scenario might be to sedate that patient. So it oddly doesn't have to be imminent. So that's interesting. So I'd know that. I'd look at the self-defense legislation in our criminal code because that might give you more help for risk to others or yourself. It won't help you with risk to themselves. That will be either Mental Health Act or something else. And it is. I think you guys are in the tricky situation. And in general, I would rely on the fact that if I don't have a lawful right, just document that that you didn't find them to that capacity. And even if you did, you've got to make sure that you've got a lawful right to do so. And most of the time, you don't. in your role. You're not being included in those legislations, which is a problem.
Yeah, we're relying on a lot of the other acts rather than the Mental Health Act at the moment.
Yeah.
In this last 6-month, 12-month period. But I think there's petitioning happening to get us written into that Mental Health Act.
Yeah. And you should be written in the Guardianship Act. Like you should have the same urgent treatment provisions that we have. Like, but there's a lot of problems with the laws in each state. Yeah. Hi. Yes. Sorry, I can't. Maybe Quentin will do some exercise and.
Thank you. My name's Jenny. I'm from Victoria. I guess one of the problems that we have in the hospital that I work at is that some of the doctors, I don't know whether they're not educated enough or whatever, but we might have a patient who's out of control and being violent to staff, and they'll just go hands off and won't actually do anything. So you're left with a violent patient. So then you have to get security in, and to me, it's a bit over the top to have them restrained by security for such a long time because they're out of control, just because the doctors refuse to act.
Oh, you mean act in what way? Like sedate them?
Yes.
Oh, right. Okay. Yeah.
Yeah,
So,
sorry, excuse me, I should have said that.
Yeah. So, I mean, I have to look at each individual act, but generally, chemical restraint, so sedation is a form of restraint, right? The reason we tend to do it often is because it's considered a kind of form of restraint. I think that's what you're suggesting, that to hold someone down, or in some places you will use mechanical restraints, etc. That doesn't seem as nice as going to sleep and just waking up later, right? I'd prefer the chemical. If you ever get crazy, just chemically restrain me. So it's considered more humane, but you have no obligation to do so. It's just you might feel that that's the best thing to do. Why they may choose not to do that, I mean, sometimes there are times when you need that person to be assessed by somebody else. So we have a lot of psych patients who are like, if we sedate them, then we don't get that assessment for ages, right? We would like the mental health practitioner to come and assess them while they're in this state, so we can make a decision like put them under forms or involuntary care or whatever, and sedating them just delays that decision. So that might be a reason. I'm not sure what other reasons they might be choosing, because I think, as you say, well, physical restraint for long periods is often less kind and can be more risky too. But in your previous point about doctors not knowing a lot about this, no one knew a lot about this. It's just something that we've never known a lot about, and it's only because I've done this deep dive that I know a bit about it, and I'm trying to get the word out to our colleagues. Yeah. Is that it for questions on this section? One more. Yep. Yep. Mm. I think it's very tricky for you guys. I don't have an easy answer. I think you guys have been left out in the cold in terms of legal provisions. I think you've been effectively acting on the doctrine of necessity. It just hasn't been tested yet. And I think effectively that's what you're doing, because you're saying that there's an imminent risk to this person. I don't think it's imminent, but you're stretching imminent to mean they might die soon if I don't treat them and don't take them somewhere. You can easily assess their lack of capacity, and if they have a lack of capacity, like under the Guardianship Act, we would then go, you got lack of capacity, we can give urgent treatment. But I'm pretty sure you guys were left out of the health petitioners of the Guardianship Act in WA. That doesn't help, no. The Good Samaritan Act's more about protecting you from legal liability. So most states, we definitely have it, where if you go and attend to somebody side of the road or whatever, not in your professional capacity, like you're not working at the time, and you go and help somebody, and then they try and sue you because they didn't like the care that they got, you're generally protected under Good Samaritan Acts, as long as you were acting reasonably, or usually excludes you if you're drunk or intoxicated on drugs, which is a problem because often when you're out, you are drunk. So there's this kind of grey area as to whether how drunk is drunk. And, that worries me if I'm out at a pub. I don't necessarily want to get that involved if I am because I'm not protected. But yes, that's a different thing. That's about protecting you from civil liability. It doesn't give you rights. Like, everything civil gives you no lawful rights to do anything. It's all about what your responsibilities are. Cool. We're going to move on. So, capacity assessments. Now, now we're going to probably run over time, so if people need to go, they can go, but I think this is stuff that people are interested in, so we'll just keep going. So this is what decision-making capacity is. This is the lawful test of decision-making capacity. To have decision-making capacity, you need to be able to understand the information relevant to the decision and the effect of the decision. You need to be able to retain that information, at least for short periods, so that you can use that information to weigh and make a decision. And then you need to be able to communicate that decision. So that's what you need to be able to do, right? Now, the first thing is everyone can. Remember, everyone has the lawful presumption unless it's been rebutted. So if they've got a chronic lack of capacity and they've got a guardian, fine. But everyone else has capacity until you can find that they don't have these things. So, I've said that already. Okay, so what I recommend as a tip in assessing capacity is first focus on retention. Can they retain information? Because if they can't retain information for short periods, they cannot have capacity. Because if you can't retain the information, you can't then use it to make a decision, right? Doesn't matter what the decision is, but you can't use it if you can't retain it. So and if I can't find a retention problem, I then try and ask all the other questions. And if I can't figure it out, I'll say, look, is there a proxy state that I can see here that reliably tells me this person doesn't have capacity? And I'll explain that in a second. So, the reason I say test retention is because it's simple and objective, right? You either can or you can't remember stuff. And it's natural as part of your assessment. So you might start, someone comes in and like, oh, g'day mate, can you tell me your name? Do you know why you're here? Do you know how you got here? My role is I'm a doctor. This person's role is they're a nurse. So I'm asking some questions, and if they don't have the answers, I then give them the answers. So you don't know where you are? Well, this is, X hospital, right? How did you get here? You came here by ambulance, right? Do you know why they brought you here? They don't know? I'll tell you why. It's because they found you acting strangely at the supermarket, or you're walking in front of traffic or something, whatever it was, right? So you ask them simple questions and you give them the answers. And then very soon after that, you ask them those questions again. And if they can't remember that, or they came in by ambulance, or that you're the doctor, or that's the nurse, or that they're at X hospital, then they can't retain. And if they can't retain for short periods, boom, done, you're done. You do not have capacity. So that's the easiest way to determine capacity, is can they retain simple information for short periods? Because if you can't do simple information in short periods, how are you going to do complex information for enough to actually make a complex decision like, should I leave the hospital or should I have this treatment? Because that's a bit more complicated, because you need to think about the risks and benefits and use all that information and weigh it. But if you can't even remember how you got here, or that I'm a doctor, you're a nurse, or that, that you came here by ambulance after I've already told you and gave you the information, then you can't have capacity. That's my view. And that's why I use retention. And I've thought about this a lot over the last year, trying to figure out how to do this quickly and teach other people, because it's so important whether they have capacity or not before you move on to the next step and take away rights. It's very objective whether they can or can't do something. And the other side benefit of why retention's so important is if they can't remember those things, if they've got no short-term memory that's working right now, they're very unlikely to remember the next steps that happen, which is where you take away their rights, right? And to sedate them, etc. The next day, they're very unlikely to wake up and go, I'm so annoyed at you that you did all this stuff. I'm going to sue you, blah, blah. Because they can't remember it, right? So that's good for you, but it's also good for them because they don't have any psychological harm from being restrained and sedated, etc. So it has a beneficial side effect of that being the case. But that's not the reason for doing it. The reason for doing it is because it's a core part of capacity. Yes? Yeah, okay, we'll get to them in a second. We'll get to them in a second. They're difficult and they have capacity, and they're difficult and they have capacity. We'll get to them in a second. So let's say they can retain simple information for short periods. Then you need to do the rest of it. So can they retain the information, and then they can use it to make a decision. So then you need to give them other information like, okay, the reason you're here is this. We're concerned that, you might not be thinking clearly, or that you might have a head injury, or they might have this condition or whatever. And we're concerned that if we don't do these tests or treatments, that you might go home and come to serious harm, such as this and this. And you need to give them that information and see if they can use that to make a decision, right? And unfortunately, the tricky part about that is that the courts have been very clear that the actual decision itself shouldn't tell you whether they have capacity or not. Because you can't go, oh, that's a stupid decision. This person can't have capacity. What you're assessing is, can they use information you've given and weigh it and make a decision, even if it's a silly one. But are they showing they can take the information? And that's why retention is so useful, because you can say, okay, I explained some risks to you, like this could happen. Do you remember what the risks are that I explained that could happen if you don't come with me or don't do this test or whatever? Do you remember what could happen? And they go, yeah, I could have bleeding in my brain and I might die. They know that risk. They just have different set of preferences than you, different value judgments than you. That's fine. So it's about, can they use it to make a decision, even if the decision is not one that you like or seems quite stupid. Now, if you can't finish that, because often you do have patients who are being an ass, as you say, going, they just tell you F you, right? And they won't answer your questions. If you think they're choosing not to answer your questions, then that you cannot find a lack of capacity. What you're looking for is an inability to answer those questions and do that process. If they're just not cooperating, all you can do is incentivize cooperation and come back and reassess. Now, if in that time they leave, you're a bit stuck because you had no lawful right, so you can't do anything. But incentivizing goes like this. Okay, look, you want to get out of here? I'd really love to get out of here. If you can answer a few questions for me, we can get you out of here. We might be able to get you out of here. Is that what you want? Because I want to do what you want to do, right? So if you can just help me with answering these questions, we can get you out of here, right? So you incentivize them to make them want to answer those questions, right? But in the reality, if they decide to walk out the door, you wouldn't be able to do anything because you haven't found them to not lack capacity. So if I can't get them to cooperate with all those questions and answer them all, and I believe that they can't, then what I'm looking for is what I refer to as, am I obviously identifying a proxy state, a state where they clearly in that state can't have capacity because they just can't conversationally interact at all. It's not that they don't want to, they just can't, right? They can't have a conversation, they can't take in information, let alone the complex information about making this decision, they just can't conversationally interact. And that would be, for example, someone who's unconscious, right? Or has a reduced GCS. They can't have capacity, right? As opposed to sleep, where you do have capacity, you just need to wake them up and let them have capacity, right? So some severe toxidromes, like severe alcohol intoxication, where someone is, and they're like staggering of gait, severe staggering with severe slurring of speech, reliably indicates a person who does not have decision-making capacity. And it also shows you somebody at high risk because they can fall over and hit the head imminently. So you've got both capacity problems and risk problems. So that's an easy one. But some people are much less drunk than that, and then they're probably okay. And here's another key thing. Merely being intoxicated doesn't remove capacity. Intoxication does not remove capacity. It has to be significant enough to impair those things that we talked about. And even if you would make different decisions, so even if you make different decisions when you're intoxicated than when you're not intoxicated, that doesn't matter. You're allowed to do that. In fact, that's one of the reasons people get intoxicated, is to make different decisions and have different experiences. And they're allowed to do that. As long as they can actually make those decisions and use that information you give them, they might make high-risk decisions. That's often the case, but that's okay. They chose to be intoxicated. The question is it so severe that they can't make those decisions? And then obviously things like really severe acute confusional states, like the really delirious elderly person, the really thoroughly psychotic person, you're trying to have a conversation, you're watching them having conversation with other people, they just can't have an interaction. They're not interacting, they're not actually taking in information. The information they're giving out has no relationship to the information that's coming in. Right? So if they can't conversationally interact at all, you've, in my view, recognized a proxy state that clearly denotes an inability to do the capacity test, to do the thinking required. And even though I couldn't ask them every question, because they just couldn't actually have a conversation, they don't have capacity. So, and if you're having trouble, get senior help, because the more you've done this, the better you are at this. So get someone, if you can, to help you in that decision. So this is a little flowchart I've made about, how to rapidly assess capacity. And first is, as I said, you must assume that they have it. Test retention, can they, retain simple things for short periods? Great. If they can, you complete the assessment. If they can't, you can't have capacity. Right? If you can't retain, you can't have capacity. Then try and complete the assessment, ask them the rest of the questions, give them information, see if they can make decisions with that information. And if they can, they have capacity. If they can't, they don't. But if you're unsure, which is not often the case, then, is there a proxy state that they just can't conversationally interact at all? Yes, they don't have capacity. No, then you still have to assume they have capacity until you can show otherwise by repeated assessment, etc. This is just my opinion as to what a rapid capacity assessment looks like. I probably will try and get this published, but I think this is how I am now thinking about it. So, and this was just the different parts of that algorithm. Now, the gray areas we've talked about is the person where you haven't had a chance to fully assess their capacity and they want to leave. Generally, you can't do anything about that. Like, they have capacity until you've shown otherwise. The other difficulty is capacity is time relevant. So you might not have capacity now, but a bit later you might have capacity. And that was that case at that hospital where the guy was drunk and unconscious. Well, as soon as he wakes up, his mental state has changed and you have to reassess capacity. And we always thought that once we had said you don't have capacity, well, that was the case for the rest of time until I came back in the room and said that you did have capacity. Turned out that wasn't the case. I thought that was the case. We all thought that was the case. That's not the case. We don't have those powers. We thought you had enough capacity. At this point in time, as soon as your state changes, we have to reassess you. And in general, if you become conscious again, the lawful presumption of capacity returns, and you need to rapidly reassess them. So sometimes I make capacity assessments like a priority 1 event when someone changes, because I need to make sure I can assess them before they just walk out the door. So that's all about capacity. That's all about the law. I'm now going to talk about the drugs. Drugs. I said we are going over time. Is that okay, guys, to go over time? Yep, cool. So this is sedation of the agitated patient. If you decided that it's time to sedate this person, and you have the lawful right to do so, and it's in their interest, and the risks are significant, then do so. And this is how you do it. So this is obviously just educational information. Once I've spoken to you, it doesn't suddenly make you competent to do sedation, but it hopefully will help you along the way. And if you're not competent, using these drugs and these doses can kill patients if you don't do it properly. So make sure you take this information and you put it within your normal local protocols and etc. And that's my big fat disclaimer. Now, so the first question with chemical restraint is, what are the risks that require reduction? Make this your first question, right? What am I trying to reduce? Is it a risk of patients harming themselves, either by directly harming themselves right now or by leaving the hospital in a very disordered state and coming to harm that way? Or is it a risk of harming me and other staff? Or is it a risk, the other risk is, those are the two big risks. And then I then have to balance that against what are the risks of the sedation drugs I'm going to use, right? Consider what resources you have, right? In some environments, we can go quite hard and fast with our sedation because we've got the right tools and resources to do that. In other environments where there's less of you, in less critical care areas, you might want to go a bit slower and a bit more safely because you're a bit worried about sedation. But I'll show you why there's an argument both ways there. But once you've decided that, it will decide on the speed of sedation and the drugs that you'll choose. So if I've got a highly aroused patient who's at high risk to staff, then I'm going to sedate them rapidly, as fast as I can, right? This protection of you and other staff members is your number one priority. Always your number one priority. So that might mean rapid sedation, or it might mean I don't have the resources to sedate this patient. Step back, let them walk out, right? You never have an obligation to put yourself in harm's way. And if a health worker gets injured, it has a very severe chilling effect on the rest of the health workers. It massively affects morale. People stop working in that job. People start leaving that job. People are having more sick days. We have less experienced people treating patients, and more patients end up being harmed and dying because that health worker got harmed. So remember, your protection is number one priority. If you can't do this safely, walk away, let them walk out, call the police. Now, so what you're trying to balance here is the patient's risk from the agents that you're giving them, their risk of harming themselves by directly harming or walking out, or risk of harming staff, and then deciding on speed, balancing those risks. And your resources. So in places, maybe like the ambulances, so you often see in protocols in ambulance services, in like wards, inpatient wards, some of the smaller EDs in the country where you've got less resources, less people who are highly skilled with sedation, they'll often talk about, let's go IM, often IM dosing. They don't like to use benzos. They'll often talk about using droperidol first, which is a great option, by the way. And then if droperidol doesn't work, maybe use it again. If that doesn't work, go straight to ketamine, or sometimes just go straight to ketamine. And they're very anti-benzos. And that kind of makes sense. If your only option, your best option is IM dosing, IM benzo dosing isn't awesome. It has some downsides, which I'm going to talk about. But if you can get an IV line in safely, I think in many situations that's still safer. I think this general rule that if it's a resource poor environment, you shouldn't be doing things IV, I don't think it's true, and I don't think the evidence backs that up, and I'll explain why. But of course, in areas where you've got high critical care skills, high restraint skills, you've got security, you've got people who do this every day, then we're generally going to stick an IV line in if we can and titrate rapid IV sedation, and we will be using benzos most of the time. So, all of these doses are for non-elderly adults, right? So if you're elderly or you're frail, generally you start with half the doses I'm going to mention. Now, all of this is on my website, which I'll show you the link after. So everything from here on in is on my website. You don't have to take photos, but you can if you want. So the first line, we would generally go with a combination of benzos and antipsychotics, depending on how aroused they are. But if you've got a highly aroused patient, and you give them antipsychotics, so if you give them 10 of droperidol, and I'm just going to talk initially about IV dosing. If you give 10 of droperidol IV, or you give 5 IV droperidol and 5 IV midazolam, the latter is better, right? The latter has been shown in randomized trials to sedate them quicker, for longer, so you need less redosing, and it has no increased side effects. So people go, oh, I've added a benzo, they're going to stop breathing. No, because you add in a benzo at a low dose and you titrate it to effect, and by doing that carefully, it actually is no more dangerous. So IV dosing of benzos, if you use the right dose in the right frequencies, I don't actually think is more dangerous than IM dosing. And in fact, I think IM dosing of benzos is much more dangerous. The reason IM dosing of all drugs, but particularly benzos, is in many ways more dangerous to the patient in terms of sedation, is you don't know when it's going to kick in. So you don't know when to give the next dose, right? If you follow the guidelines, you have to wait 15 minutes. Well, that's going to be fun. Waiting 15 minutes with a highly agitated patient until you give another dose. So then you don't do that, so you end up doing it quicker than that, and then the first dose kicks in, and then the second dose kicks in, and this person's out for the count. And that's why when you're doing IM, they'll often say use droperidol, because it has less airway breathing problems, not none, but less, and then go to ketamine. Or they're really aroused, just go straight to ketamine, right? Because you might need control quickly. And that's why they don't want you to give so many benzos IM. And I think that's not unreasonable, but I'd rather, if you can, get an IV in and do this much more safely, because you can titrate rapidly, quickly, smaller doses, but more often, and because you've seen the full effect before you give the next dose. So I'll give you examples in a second. Similarly, if you use a benzo IV by itself, the amount that you need to give to get that sedated patient is so much more that you'll get more breathing and airway problems. So that sweet spot of synergy with droperidol and midazolam is the reason that's the number one thing that we use in EDs, is because they both offset each other. We can use less of both. I don't have to use 10 of droperidol. I don't have to use 10 of midazolam. I can use 5 and 5 and get a well-sedated patient much more safely than going big doses of other drugs. And I can give a dose and then wait 3 to 5 minutes and then give another dose, because I've seen the most of that effect already before I give the next dose. And to me, that's a lot safer than giving a big IM dose and then just waiting for some indeterminate amount of time before I give another dose. I don't think that's actually safer. I think that's old thinking, and I don't think it's a good idea. But sometimes it's all you can do, and we'll talk about that in a second. Oral agents, obviously, if they're cooperative and you don't need to be, you can have a slow sedation because they're not a big risk to other people. Obviously, go oral first. But if they're not cooperative or you need rapid sedation, oral is not your friend and you shouldn't be using it. These are some doses. Lorazepam or diazepam are commonly used benzos. Olanzapine is probably the most commonly used antipsychotic because it's a wafer and it acts quickly. And often they'll be given together. In a mildly aroused patient, you might give 1 of Loraz and 5 of olanzapam. In a more aroused patient, maybe 2 and 10. But again, if they're very aroused and a high risk, you're not going to be doing oral in the first place. And then let's talk this big debate between IV and IM, right? I've read a lot of guidelines, and a lot of people, again, in resource-poor environments, keep talking about IM as being safer. Now, here are the benefits of intravenous. As I said, rapid onset, rapid titration. I can give small doses of midazolam. I can give 5 midazolam. If you're really scared, give 2.5 midazolam. Whatever. You can do it again in 3 minutes, right? You can assess response and give it again. That's way safer than giving a big 10 IM dose. Way safer. Or even a 5 IM dose. Although, 5 IM dose is quite safe, but it's just going to take ages before you'll be comfortable to do it again. And then, inexperienced hands, I think that's actually way safer. In inexperienced hands, if you're not used to giving IV dosing, yes, you can screw this up. You can give the wrong dose or the wrong frequency, and you can make this person worse. So you want to make sure you get experience with this, and you get advice with this, or you talk to someone who's experienced when you're giving IV dosing. But if you have experienced hands, doing the right doses, the right frequencies, I think it's safer than IM dosing. That's my personal opinion. Now, if you don't have an IV line-in, you need a restraint team who can get an IV line-in. Now, that's very easy in most EDs where we've got burly security guards and we do restraint many, many times a day. And we can usually immobilize someone's arm long enough to put a line in. It's not a hard thing to do. We do it all the time. But the less resources you have, the more peripheral your hospital might be, the less security you have, the more non-security people having to mobilize the arms, it's much harder to get that line in. You need a much more cooperative patient. Now, some patients start uncooperative, but once they realize they're being restrained and getting sedation, they often start to become much more cooperative. You can get a line in. But some stay uncooperative, and you might decide, actually, this is not going to work. I'm not going to get a line in. It's too unsafe for me to try and put this sharp into them while they're moving around. Fine, give them an IM dose. So your choice of route, it has to be dynamic with the situation as it evolves. So sometimes I'll walk up to the patient with IM doses, so not diluted up or anything, because I'm going, if I can't get a line in, then I'm going to be going IM, right? But my preference is IV if I can get it in safely. But if you've got less people, you can't do the restraint, you can't keep this arm still for long enough, then you're going to have to go IM, right? At least for your first dose, and then once they're more settled, then maybe you can get your IV in and then titrate things, I think, more safely after that. Now, the problem with IM, as I said, it's slower onset. takes longer. You don't know when you can give another dose. Particularly with benzos, most of the guidelines talk about 15 minutes. That's way too long. Droperidol, you can probably give another dose at 10 minutes IM. 10 to 15 is what a lot of the guidelines say. So you can give that a bit quicker. And if you overshoot with droperidol, it's not as big a deal. They get sedated, but they don't have as much of an airway breathing risk than if you gave midazolam. That's why if you're doing IM dosing, you prefer droperidol or ketamine, which is also very safe. So your risk to the patient might be less in terms of their sedation risk, but the risk to you and everybody else might be higher because they take ages to get sedated. Now, if this is a highly agitated patient and you give them an IM shot, and now everyone has to hold this patient for ages before the IM works in or before you give another dose, that puts everyone at high risk, including the patient. Like a forceful restraint that goes on for 10 minutes, 15 minutes, puts everybody at risk, including the patient. So that's why I think IV is better, because you want to get this done quicker. But only if you can, right? Only if you've got the people to get that line in and do the safety, and you've got the skills to give IV dosing and the right doses. Equally, if you've got a person whose risk is of harm to themselves, but not to you, right? They're placid, and you don't think they're going to harm you at all, and you just worry about them leaving and killing themselves or harming themselves now, then that is a patient that you might be able to restrain just for briefly to give them the IM shot, and then everyone backs off, right? Walks away, leaves them alone, because you're not worried they're going to come and punch you out, right? Because they were never a threat. They don't see you've made an assessment you don't think they're a threat, so you might IM shot them and walk away. That is a reasonable thing to do. Right? If you can't get a line in, that is actually quite a reasonable thing to do. But if you think that they might react very badly to this restraint, or they're very highly aroused, and you let go of them and they punch somebody out, that is bad. You have to avoid that. So you have to be very careful about whether you give that shot and walk away, or you give that shot and hold until they are now placid enough that you can get a line in or give another shot or whatever. So be very careful. So this is why I say IM is not suddenly safer. It has a lot of risks associated with it. So here's some doses. Droperidol, 5 to 10. Usually, like if you're going IM, you'd often give 10, and then another 10 up to 20. If you're going IV, you could give 10, but I'd much more likely to give 5 and 5 with midazolam. So that's been shown in studies to be better sedation, faster, and no more unsafe. And then, yes, reduce it if you're giving IV dosing or giving midazolam. And then if you can't use droperidol for some reason, like they're allergic, you can use olanzapine. It's only licensed IM, but there's studies that use the same dose as IV, just like droperidol, and found it to be pretty much as good. The EGG mentions that, but it's not licensed technically IV, but no is ketorolac, no is Stemetil. Like a lot of things are not licensed IV. We use IV from studies. But unless you've got an allergy to droperidol, I would always use droperidol because it's our best. It's our best famous antipsychotic sedating drug. Benzos, midaz is what we'd usually use to get someone down quicker because it's rapid acting. You can give it IV and IM. And, here's the difference between sedation and, say, status epilepticus, which you guys would also deal with, right? In status, you don't have a line. You'll give them IM midaz. You might give them 5. In some things, I'll talk about 10, which is a big dose. And then you'll give it 5 minutes or so, and it's all seizing, and you might give them some more because it's a different risk-benefit here, right? Status epilepticus is a life-threatening, neurologically devastating condition that you will accept sometimes overdosing them in order to terminate the seizure. This is a bit different. It might be like, if it's life-threatening to you, then yes, you'll accept overdosing them. But I think you might accept that IM by droperidol or by ketamine rather than midazolam. But in status epilepticus, you don't have any other options. So you'll use IM midazolam and you'll get a line in as soon as you can, and then you'll give it IV. But until then, you'll give repeated IM doses quicker than you would in sedation. And when you want a longer sedation, I've mentioned the IM dose here, 5 to 10. 10 is a decent IM, it's a big IM dose, and I think that's definitely more dangerous than giving IV 5 and giving more if you need to. And that's why I'm very nervous about IM benzos. I'd much prefer to give them IV, where I think they're actually quite safe if you do them carefully. If you need longer sedation, like the biggest mistake that happens in EDs, someone gets droperidol 5 and 5 with midazolam, and then an hour later they start waking up and someone gives them more midazolam. And I'm like, hang on a second. I mean, give them more droperidol firstly, because that's quite safe. But if you think you need more benzos, and you need them sedated for 10 hours, then maybe move to something that's going to last for 10 hours, like diazepam, and titrate that to your level of sedation, because you're looking for a long sedation, use a long sedation drug rather than giving a midazolam every hour. And that's when you often see people going up and down in conscious state, and that's when sometimes they aspirate. You don't want that rapidly changing conscious state. The other time I use diazepam is when I've got a long problem, which is a toxidrome, and I'll talk about that in a second. So as I said, combinations I think are, and I think the evidence shows as the safest and quickest acting, or at least as safe and quicker acting. And that's the classic combination, 5 and 5 IV. In a normal adult, not elderly, not frail. Now, we all have our patients who are very hard to sedate, right? Either just because of genetics or because they take a lot of other drugs and they've got, their receptors are very resistant. So, ketamine is your friend in those such patients. Ketamine works on everybody, basically. It doesn't, the beauty of ketamine is it doesn't really sedate you, it dissociates you. I've been dissociated on ketamine, not recreationally. I broke my femur. It was an absolute bitch. And thank God for the paramedics and thank God for ketamine. And sometimes when you have pain that is, I can tell you, indescribable pain that I literally wouldn't wish on anybody. The only way for that to work, like fentanyl just didn't cut it no matter how much they gave me. The only way for that to work was to no longer be in the room anymore. And ketamine will put you in a different place. You will disassociate your brain from the rest of your body and the room around you, and you're no longer there. And even though apparently when they move me on the stretcher, I'll be other drugs. Way lower. You generally keep breathing. You generally keep your airway. There are some rare risks of laryngospasm, but generally that's not that common. If you give an IV bolus that's large and really quickly, you can get apnea. That is a thing that can happen. But if you don't give it really quickly, apnea is rare as hen's teeth with ketamine. So that's why if you're giving an IV, if you've got a line you're going to sedate somebody, then usually you're going to need like 1 milligram per kilogram often to sedate that patient. But I would often give 0.5 mg per kilogram and wait 60 seconds and then give another 0.5 mg per kilogram rather than bang it all in at once, because that's when you might get the apnea. And the other thing is when you combine ketamine with other stuff, because you've often not reaching for it first, you've often already given them droperidol, you've already given them midazolam or something, you often need a lot less ketamine to get them dissociated because of the synergy. So often they'll dissociate 0.5 mg per kilo without needing to go to the full mg per kilo. Right? So that's why I'll generally give 0.5 mg per kilo boluses, but rapidly. Midazolam, you need to wait 3 minutes before you see most of its effect. Ketamine, 60 seconds. If you give it IV, in 60 seconds, you've seen most of its effect, and if it's insufficient, you can give some more. So this is why when you do IV dosing, you need to know your drugs, you need to know what your time periods are before you redose, and if you know that, you can do it safely. And IM, of course, is 4 to 5 mg per kilo. It's a big dose. And the thing about ketamine, if you're not dissociated, the treatment is you give more ketamine, right? And if you give more ketamine, you just get dissociated, and it doesn't seem to add any other risks. So it tends to be bigger doses that you need to get them to where you want to. It's that in-between stage with ketamine, when they're coming into the K-hole or coming out of the K-hole, that's when they can be a problem. And that's when often the solution is more ketamine, if you need them to stay in that place. And then I think these guys are underutilized in ED, certainly by me and my colleagues. I don't think we use them enough, and I'm starting to use them more. These are essential. This is not for paramedics. I don't think you'll have these, but in ED, we don't have these in ED. We often have to get them for ICU. These are generally ICU drugs, but there are some patients who are really, really hard to sedate. And even though ketamine is good, because of those behavioral problems that you get on the way out and in, it's not like I don't like to use it if I don't have to use it, but if I do if I need to. But these guys can often, they turn off all your sympathetics at a central level. So all that sympathetic adrenaline and that surge goes away. And it's remarkably calming in some patients when you've tried all these other drugs. And so, clonidine, you can give that IV, but people prefer dexmedetomidine because it's slightly less like problems with blood pressure and slightly better sedation. But they both work, but they both have risks. If you turn off your sympathetics, you can get bradycardia. After a transient hypertension, you can get hypotension, which is long. It can interact with other medications like beta blockers. If your patient needs their sympathetics to live, like they've got septic shock, not a good time to turn it off. Yeah? If they were hypovolemic shock, not a good time to turn it off, right? So sympathetics are keeping them alive. So don't start reaching for this all of a sudden, but just have it in your knowledge bank and maybe take advice from somebody who uses it a lot, like an intensivist, before you start using it. But it can be a good option at the back end with these guys who are really hard to sedate. And generally much safer on airway and breathing because it doesn't affect airway and breathing, but much more dangerous for C, much more dangerous for your circulation. So you've got to pick your right patients. And then, of course, there are other non-drug strategies. So you've got to obviously optimize your non-pharmacological strategies that we're not talking about today. But also make sure you've kind of investigated and treated all the other things that might be making it worse, right? If they're hypoxic or hypercapnic, if they've got, BSLs out of whack, they're hypertensive, treat all the other things that you can treat that might be affecting their mental state. Treat pain. One thing I've found in some patients who are really hard to sedate is people who are really agitated and aren't communicating with you don't express their pain very well. And sometimes I'll just titrate small doses of morphine, carefully, because I might have already given them benzos and things. It's going to make them more risk of apnea and things. So you got to be careful, do it slowly. But even like 2.5 milligrams at a time, every 10 minutes or so, or even fentanyl or something, and suddenly, just 2.5 milligrams in, they're sedated, they're relaxed. And it was probably some undiagnosed pain that they were not expressing that got rid of their agitation. Or it just turned off the sympathetics like clonidine or dexmedetomidine, because opiates are really good at turning off your sympathetics as well. So that's another thing, is just consider pain. But if you're going to treat it, be careful, because you might be using other drugs and you might get more airway and breathing risks, and make sure you've got naloxone handy. The bladder. Don't forget the bladder, right? With agitated patients, particularly anticholinergic syndrome, but anybody with bladders, with sedation and toxidromes, everyone with bladders, we will do 4-hourly bladder scans, and if they get retention, put in a catheter, because that worsens your agitation. Toxidromes, sympathetic, serotonergic, anticholinergic, these are classic ones that people are really aroused. The treatment is benzos, primarily, because you're both treating the agitation, but you're treating the autonomic dysfunction as well, which can be dangerous, like the severe hypertension and tachycardia. So you're treating those parameters, and titrated long-acting IV diazepam is your friend in treating those. And once you've got those parameters in play and where you want them to be, if they're still agitated, then you might add, something like an antipsychotic. Or if they're so agitated you needed to get the control, you might add that droperidol straight off the bat. Just with one warning that if it's anticholinergic syndrome, if you think it's that, don't use your antipsychotics usually, because it worsens it, because it's another anticholinergic load. And monitoring, obviously, these patients are at high risk of bad things. So at the very least, you need to have more intensive nursing ratios. In many ways, your ambulances are actually better than that, because you're one-on-one. And continuous saturations and regular blood pressure monitoring. That is the minimum essential, I would say. The ideal in an ED environment would be CO2 monitoring, right, with like using nasal prongs. I think that's ideal to make sure people don't stop breathing. And we've got it, so we throw it on, continuous cardiac monitoring. It's ideal, but I don't think it's crucial. And then, of course, as they wake, reassess capacity, reassess risk, because you might not need to keep sedating them. And you might not be lawfully empowered to either. Resources. So on my website, I've got all this stuff this way. So this is my website, ED Guidelines. It has a whole lot of guidelines for everything in acute care, critical care. It's useful to kind of GPs, ambulances, urgent care, and EDs, obviously, specifically. It's all free. It's just, I make no money from it. It just costs me an enormous amount of time, unfortunately. But there's a section called Tips and Tricks, where I write my own kind of guidelines and articles, and in there, a few of these things you'll find. So the sedation of the agitated patient, that whole section we just talked about is all there. And then if you want to look at that legal stuff, the resources regarding restraint and detention of patients has a few things. It has that Emergency Medicine Australasia article. It has, if you're in WA, you're lucky on this point, because I am as well. And so I spend a lot of time looking at our legislation, and that article I put on my website goes into all our legislation in detail. And there was like another webinar we did with a lawyer as well. And this is the flow chart I showed you before, but when to consider restraint, and that comes from that article that we published in the major journal, and that one has in it that flow chart, but also those 5 case examples that I think are really good, and it gives you the answers. What would you do in that situation? Do you have the right to restrain them or not? I thought that was actually quite helpful from that article, and this is for a national audience. That, I think, is that. Sorry to go over time. I hope you found this useful and interesting, and happy to take any questions on any of the stuff that we haven't yet talked about.
Fantastic. Let's hear it for Anand. So thank you very much for the time you put into that, and also for sharing some amazing tools that's relevant for everyone in the room. So one more time for all our presenters, so Matt, Caitlin, and Anand for today. So that brings the first, afternoon to a close. If you've got any questions, unsure about anything, please see myself and Dylan at the front. Otherwise, Max and Delphine from Local Life will just be out that door. And in particular, anything to do with the Balis and surrounds. If you want any some tips and tricks, they're definitely the ones to speak to. Go have some fun tonight, but not too late at night, because it is a 7:30 start tomorrow morning. We will have morning tea from 7:15, so some sort of like, I think it was like some ham cheese croissants, those sorts of things. Lots of coffee. If you're unable to make it in the room, we will be streaming live. And so you do need to find those links. They're all in the info book. Apart from that, enjoy, and see you guys back here tomorrow. Cheers.